Good morning. That's a check to make sure everyone's volumes are down. Good morning. I think that's better.
Yeah.
Okay, good. So let's go ahead and call the meeting to order. Welcome everyone to our November 2024 meeting. So welcome to the NEC members and guests. Reminders. One, keep your speakers off if you're in the room, and your volumes down as well. This event is being this meeting is being recorded. It will be posted on our website when we're done, once it's available. Closed captioning is also available for the meeting. If you need closed captioning, there should be an icon at the bottom of the screen. Before I jump into taking attendance, which I need to prep for, I would like to remind everyone that we do have 6 NAC members who are retiring in March of 25. There they are. So this will be their last in-person meeting. You still have responsibilities through March, so you still may get called on. You do not get to bail out early, but this is the last in person. So thank you all for your service to this wonderful council. There will be, from a logistics perspective, there will be both retiring members as well as all members will take a NAC member photo when we break for lunch. Just remember to do that. And then I think we have maybe individual pictures or a group picture with Bob as well for retiring members. All right, so that is that part. I'm gonna pop the next, is it next slide or did I just run the list? Did I? Okay. Okay. All right. No, that's for comments. Well, let me take attendance first, and then we'll get to the comments part. So, Peter, I saw. Is David Ash on Zoom? Dr. Angut's here. We'll check for Dr. Ash. Kamal's here. Al's here. Mason, I thought I saw. Yep, Mason's there. Joan is here. Cynthie's here. Sharon's here. Krista's here. Sunil's here. Carrie's here. Mary Beth, Michael. I think Mario's not here today, right? Okay. And Beth Moore. She was on this morning as well. Okay. Kanan was on. Yeah. Okay. Here. Gina's here. And Jaji's here. Okay. Who do we have from ex officio? Michelle, Shriver. Anyone else, either in person or online? If there's any ex officio members who are on line, please unmute yourself and just say that you're here.
Hi, this is David Hunt from ASTP.
Thank you, David. Capture that. Anyone else? I think that is it. All right, so we've got our attendance Yeah, I just saw the note. Thank you. All right. So let's go into our comment section. So how we'll manage the meeting as a hybrid meeting is you can make a comment in chat during the next meeting. In order to make a comment though, for folks outside of the room, please go ahead and send an email to National Advisory Council at ahrq.hhs.gov. And the subject line is real-time post. We'll incorporate that into our proceedings. That's just members of the public. You guys are already been promoted to panelists, so you can make actual chat comments. NAC members can make chat comments at any point. The formal verbal public comment will be at 1 o'clock Eastern. In order to make public comment, I'm sorry, it will be at 3 o'clock Eastern. In order to make public comment, you have to send your email by 1 o'clock Eastern to National Advisory Council at ahrq.hhs.gov. Subject line should say public comment. If you get that in by 1 o'clock, you'll be pulled into the public comment that happens at 3. And each comment should be limited to 3 minutes. All right. Oh, yep, sorry. Just for public comment, please be respectful with your comments. Any ridicule, obscene, or profane language, personal attacks will not be accepted as public comment. For both the real-time and public comments, you ask that you be brief and to the point, preferably addressing issues that are on the meeting agenda. So as a reminder, for the only NAC member can see comments that are in the chat. So if you want to make sure that it's part of the public conversation, you actually have to speak it. So just, and we'll call on you, you guys, well, you can actually, NAC members can either raise your hand in Zoom. I'll track that. It actually, that's probably the easiest way, even though I can see you all. It's probably just do this so I can, because what happens when you raise your hand in Zoom is it goes by order of the person who raised their hand, so I can catch you by the order of the person who raised their hand. So that is how we'll manage both in-person chat as well as the verbal comment, public comment. All right. So the first order of business is, now that we've got through the logistics, is to approve the minutes from June. So hopefully you've had a chance to review those minutes that came in your prep packet. So given that, do I hear a motion to approve? Motion's been to approve has been submitted and seconded. Anyone opposed to that approval? Hearing none, those minutes are approved. All right, let's talk about the agenda for today. We have a packed agenda, lots of discussion. So for the members of the public who don't know, prior to the meeting, NAC members met in small groups for pre-work. So that work will be reported out during the CAPS and patient safety sessions. The meeting will start off with an update, of course, from our ARC director, and then we'll hear from ARC's Patient-Centered Outcomes Research Trust Fund Extension Program, and we'll have a presentation after that. We'll have a presentation and discussion on updates from the National Action Alliance to Advance Patient Safety, SNAC. And then we'll hear from the CAPS team around vision and strategy. Again, raise hand function, and we'll just jump right into it. But I expect and I'm fully confident that we'll have robust discussion around these very important topics that we're going to be covering today. With that, I want to turn it over to Dr. Valdez, and let's jump into the report out.
Thanks very much, Mundo. It's a real pleasure to be with you again this year and this month. As many of you know, this will also be my last National Advisory Council meeting in person with you. But as Krista Hughes was reminding me of what I've said to all of you when you join the National Advisory Committee, once I've got my teeth into you, I'll never let you go. So while I may not be sitting in this chair, The mission of ARC to improve healthcare has always been my professional and personal passion. And so I know your talents. I know where to find you. I have your phone numbers and your emails. So I will be contacting you to continue pursuing that passion to try to improve healthcare in our country and abroad as well. For those of you who have been with me for the tenure of my period here at ARC as director, I will also be rotating off with you as the new year arrives. Because I've been in and out of government so long, instead of resigning, I will be retiring, just as you are. And so I look forward to that period of retirement. It'll be my third. So obviously, that's why I said I have my teeth in you and we'll keep going together. I first of all wanted just to bring you up to date on discussions around ARC's budget and what we might expect. We're currently operating on a continuing resolution through December 20th. Current discussions on the Hill suggest that there's some desire to continue a continuing resolution into March. But there's other sentiment that folks would really like to have a nice, clean 25 budget in place so that the new administration would have an opportunity to pursue its agenda without other distractions. So where that ends up is anyone's guess. We're constantly monitoring the situation on the Hill, and later on today, I will make a trek up as well, as I've been promising others that I would constantly be working on trying to secure our 25 budget for ARC. The administration transition, of course, as you know, will take place in January 20th. The last business day for this administration is the 17th of January, so that'll be the day of my retirement. But thankfully, your tenure of this council, which provides the guidance and direction for ARC, continues on for those of you who are retiring through March. And then we have already identified, I can never say your replacement, but new members of the National Advisory Council have been appointed by the Secretary, so that we won't have as we have in the past, a council that was not fully equipped to move forward and to provide the guidance and support that this agency requires, particularly in today's period with massive changes in the way we do work in healthcare, and particularly the introduction of generative AI, which is changing the way people think about their jobs and think about the tasks that they need to pursue. So we desperately look forward to your guidance and your support as we try to continue to figure out how to help health systems provide high quality care to everyone. And we won't be able to do that in a fast moving marketplace and environment unless we actually have contact with patients in particular, and with those of you who are part of the healthcare ecosystem that provide the sort of larger understanding of not the elephant in the room, but the many elephants that are in the room, because every health system and every community is quite different. I'd like to spend just a few minutes to highlight some of the accomplishments of 2024, because they've been quite important in moving us in the direction of improving healthcare and transforming healthcare, recognizing the huge amount of fragmentation and the misalignment of incentives. The healthcare extension cooperatives were launched this year. We're expecting the first to be funded in early 25, and you'll hear more about that later. But I was thrilled with the response, because every single state and some territories expressed desire to really engage in this particular cooperative program. It's a full recognition that one of the reasons that we have been delayed, or that we see barriers to bringing innovation into the clinic or into the workspace, are socio-political in nature. And these healthcare extension cooperatives are intended to try to deal with those socio-political aspects of organization and delivery of services, as well as aligning financial incentives that prevent true medical progress. And you'll hear more about that as we talk about the updates. I'm also very, very thrilled about the National Action Alliance for Patient and Workforce Safety, an activity that we've been engaged in since early 2023 at the request of the Secretary and our discussions with healthcare executives from around the country. We've seen a spike, or we saw a spike in patient and workforce safety events in 22 and 23 that have now been reduced and are nearing sort of pre-pandemic levels. But as I've said to everybody, pre-pandemic levels was not something to be happy about. So we still experience at least 1 in 4 people who walk into a hospital experiencing some kind of bad event that they never expected. And we've lost the trust of much of the public. And so it's our opportunity to help healthcare systems around the country regain that trust and to make healthcare safer than it's ever been. And we see a real movement in large part because patients are also leading the way and we're providing the support from the federal level. And you'll learn even more about that as we talk today. I'm really, really happy that part of this patient safety issue is a recognition of the burden of sepsis in our country. It's like third major reason that people die in our country and has huge costs, both to the families who lost the loved one, but also to the healthcare delivery system. And I'm hopeful that we will continue to see progress on dealing with sepsis because it's particularly a problem for people over the age of 65, a cost to the Medicare program, and now has caught the attention of leadership in both houses of Congress and on both parties. I'm also really, really happy to say that we've put on some new tools to improve healthcare in a variety of different ways. The one that's noted here is that we have an online tool that improves the prevention of opioid misuse and opioid use disorders in older adults. And increasingly, much of our work is recognizing that we have to adjust to the fact that we have a very rapidly changing population of older people, but we also have a younger community that is highly diversified. And so both the increased diversity of our country at the younger levels and the increased size of the older population are putting great strain on healthcare delivery systems to serve the two types of demands that those populations put forward. But working with my colleagues here at AHRQ and with colleagues across the department, with our CMS partners, I think we're making some progress in really getting people to recognize that transformation and to have an age-friendly healthcare delivery system is extremely important. Not only age-friendly, but whole person. And that is the department has done a great deal of work over the last 4 years to try to bring mental and behavioral health care together with the physiological health care, a real recognition that we can't keep looking at the two separately. And so the work that we've done on integrating behavioral health care and primary care is really taken off and is making great progress. We've also been engaged with a variety of efforts working with our colleagues at CDC and elsewhere to deal with MRSA and other healthcare related infections. And so I think we're making some real progress over the last few years, and progress that I think is not tied to the politics of our country. It affects Republicans and Democrats and independents alike. And so in many ways, I see the ball that we've got moving will continue to move, in large part because it's the patients who are helping us and reminding us that we need to make progress. To make some of those progress, we've been doing some other things. And In particular, we put together some summits to celebrate ARC's 35th anniversary as a independent science agency in the Department of Health and Human Services. And I want to turn over the mic to Sean Bruno, who's been my senior advisor and who helped coordinate the efforts around a summit to look at emergency department boarding and also a look at health services research and its future over the next 35 years. Sean?
Thank you for that, Bob. I'll take the remote there. Thank you, everyone. I'm happy to share about the summits that we organized. Emergency department boarding is a practice where patients are admitted to the hospital and wait in the emergency department because there isn't a bed further down the line for them. It is a very serious national issue that impacts all of us. We received a letter from Congress, from 44 members of Congress. It went to the secretary and asked us to address the issue. The secretary responded and HHS responded, and ARC answered the call to coordinate with our federal partners to create a summit. We formed a committee of internal and external experts and organized a summit in short order. The focus of the summit was how can boarding could be addressed to as a healthcare system issue to immediately and systematically improve patient safety. And we had two components in this summit. There we go. We had two components to this summit that was held at HHS headquarters. We had a morning component that was streamed nationally, and we brought in several subject matter experts to address the summit, to address the issue. We had a session on the impacts of emergency department boarding that included patients and experts and really informed the public of the severity of the issue. It spoke with multiple publics, you could say, both experts on the topic and then individuals that might not be as aware of the issue. We also had a session on myths and matters of emergency department boarding solutions, which really addressed some of the actions that hospital systems have been taking that may not be the best way to address the issue. Those were some of the myths we addressed, and we had presented, the speakers presented some other possible solutions. And we also had a fireside chat with the CEO of Mount Sinai Health System, who stressed that this is a healthcare system issue, not an emergency department issue, and that's a critical aspect of this. In the afternoon, we had concurrent work sessions to address several areas that the committee suggested we examine. Experts discussed system-wide financial and regulatory enhancements, real-time regional health system data measurement and metrics, workforce development, technology and safety issues, rural solutions, and behavioral health connections. All of the content from those sessions, both the morning and the afternoon, are being summarized into a report that will be coming out in the new year. As part of this effort, we've had a variety of other materials that we've also worked on to address the issue. We did have a rapid internal roundtable before the summit. We did have a panel at Academy Health, also to activate the research community and bring greater awareness of this issue. Again, we will have a summit coming out. We do have comments coming in from the attendees, and we're also analyzing those. Interestingly enough, people really appreciate some of the graphics we had in this session. This is one of the images there. We had an individual there drawing some graphics. This helps on social media really to draw attention to the issue, and we'll have some other works coming out in 25, in particular, an academic special issue, which would be useful for the research community. In addition to the Emergency Department Boarding Summit, we also had a summit on the future of health services research. This was an anniversary summit for the agency, and it was really an opportunity to reflect back on some of the work that has happened at ARC and also look to the future. We brought a variety of different scholars and researchers in, scholars at different ranks and different researchers, including individuals and groups that may not necessarily engage in this sort of work. For example, foundations. We really brought a lot of different voices into this. 85 participants, including health system leaders, researchers, community workers, clinicians, and patients and the such participated in this for a series of really wonderful discussions. In this, we had a fireside chat between the director and the CEO and president of Academy Health to discuss the future of health services research. We had a keynote address titled "Now More Than Ever, We Must Focus on People," again, highlighting the importance of individuals and their experiences in health services research, and a wonderful panel discussion which took participants to the future, to 2060, to really consider what's needed to transform in-person centered care. We also had concurrent breakout sessions where experts really discussed and presented possibilities for the future. They addressed healthcare settings and modalities of care, optimized implementation of HSR, intervention co-design, and evidence co-creation, partnerships that support robust HSR, real-time data analytics and rapid learning, and economic structures and economies of care. Really, they had a wonderful and robust discussion. A report will be coming out also this year that presents what they discussed. Both of these summits are available online so that people can go back and continue to learn from them. We've heard from a couple of individuals that are using these in their courses and the such. And like the Emergency Department Boarding Summit, we'll also have a series of articles coming out in a special issue in 25, again, to push the conversation forward and to ensure that researchers are not only thinking of the present moment, but also looking far into the future.
Thank you, Bob and Sean, for the highlights and the summit. As a summit participant, I can definitely co-sign on the value of the summit and the engagement that we got from what I thought was a really broad group of participants and diverse opinions and perspectives I thought we brought to the table there. It was really, really powerful. Let's open it up for questions. If anyone has questions for Bob or Sean, we'll open it up at this point. Just go ahead and do a raised hand. Go ahead, Al. You can just go.
Go for it.
Good morning. First, thank you for this recap. I did have a question on the webinar guests on the impacts of emergency department and boarding. And just, I was looking through this and I was able to view this also. And just being a pharmacist myself, was there a pharmacist? I know there's a question about who's missing from the conversation. And I think that pharmacists can serve a huge assistance here because a lot of these patients come to the pharmacy first before they go to the emergency room. And so how do we have pharmacists, those that are part of that health system and that institution, assist, and then also those outside of that space? Just curious if that came up as part of that discussion within that roundtable.
I think one of the, I'm not sure if a pharmacist in particular was there in attendance. I'd have to look back at those records. But I think one of the main things that really came out in the summit is ensuring that people do recognize that this is a systems level issue, and encouraging individuals when they start to work on this to say, can we look at this in the entire system? Who else do we need to get involved? I think that certainly was one of the key points that come out from this. I think for quite some time, even by the name Emergency Department Boarding, people tend to think that this is an emergency department issue and for them only to serve. But I do think that there was good consideration to really expand beyond the boundaries of the emergency department into other areas, both upstream and downstream. So I would say we know the report is being drafted and reviewed right now, and I'd have to look in to see if pharmacy was a consideration, but that's absolutely part of it. Yeah, part of the opportunities to address it.
Alan, I'm glad you raised the issue of pharmacists, because one of the things that's alarming me and potentially is part of this dynamic in the community that leads to ED crowding, and also potentially that ultimately leads to the other part of the boarding issue, is the fact that we have so many pharmacies closing down, and particularly big retail pharmacies And so there was a time in which people could refer people just straight to the ED because they can get their medication. So with more and more pharmacies closing down, particularly in rural communities, I think we're in for another kind of dynamic that will potentially make the crowding issue more difficult and lead to additional boarding related issues.
I completely agree. I think it's one of the things that we struggle with in the profession right now, and specifically from a regulatory standpoint, as you know, as we will talk about later with looking at patient surveys and what have you with CAHPS. We're trying to figure out what is that gap that regulatory bodies can help reduce, or what are some of those burdens that they can reduce to allow better access, because you have these 24-hour pharmacies and all these other access points, specifically in those rural communities and others that are closing, leading to gaps in care as well.
So, Al, thanks for those comments. And Sean, I would encourage, you do have a series of things, engagement points, right? Whether it's the blog, I don't know if you put the blog post out yet or not, right? So you still have some room to start to potentially engage around calling out Al's question and incorporating that into your work potentially.
Yeah, absolutely. Thank you for that. I think, as there's still time, I think, for those of us here to really put significant work and recommend and work in those recommendations. Thank you for that.
Got it. Michelle, you're up.
Turn on. I thought my camera was on. All right. Get there.
Yep.
There we go. Maybe. There. All right. Thank you. First, Bob, on behalf of CMS, we want to really thank you for the partnership and collaboration and wish you well in retirement and with great success. So thank you from all of us. The issue of ED boarding is really important to us as well. And I'm sure you looked at this in the session, but one of the biggest issues that we see in the data is ED boarding because of behavioral health, because you can't get people transferred into, because there aren't enough of behavioral health facilities. So did you address that specifically? Because we would really encourage, maybe that's almost a separate subtopic, because it has all kinds of implications. Thank you.
Absolutely. Thank you for that. That was a regular part of discussions at the summit, and certainly a key point that individuals here at ARC and our partners at other agencies have brought up. That is a major component of the issue. Absolutely. And I think both here at ARC and then certainly the partners we're working closely with at CMS and a lot of our rural partners are working on this. Absolutely. That is a central topic.
Excellent. Liz, I see your hand up.
Thank you. First of all, Bob, I just want to say congratulations on your retirement, and a deep gratitude. I wish I was there to give you a hug in person, but a virtual one we'll have to do. And thank you. And I know you won't really retire from the mission, so that gives me a sense of comfort. So thank you for that. And also, Sean, thank you for sponsoring the emergency department webinar program. Several folks I work with at the Joint Commission attended, and they came back just, vibrating with great ideas and praise for the work. And I wanted to share a perspective on the ED boarding that may or may not be helpful, but, everybody thinks, oh my gosh, it's a problem with the ED. And obviously many people are beyond that. And the way we like to think about it is it's all about the patient care. We can work on prevention. We can work on finding capacity. We can work on extending capacity. We can work on throughput, flow, all these things. And hospitals have been trying for decades on this. It's not going to be easy because we have so many forces working against us. So what we can do now is really encourage, and perhaps this is in your report, but if not, I would encourage you to think about encouraging hospitals to think about patient care. Okay, you've got patients in the emergency department. They've deemed to be needing inpatient care. How do you provide that level of care? It's all about the care. And we can do it on home care, hospital at home, ambulatory, behavioral health, ambulatory surgeries. So let's think about it a little differently, which is, okay, we've got this big problem. We need teams working on prevention. But in the meantime, there are people all over this country boarding in our emergency departments. And let's focus on how do we provide them with safe, high-quality care. If you need anybody to review your report, I'd be happy to. It's an issue near and dear to my heart.
Liz just volunteered herself, so there you go. Cincy.
Yeah? Okay, now, I wanted to underscore two things. One is the issue with behavioral health. You know, we have, even in a place that is full of hospitals, like the DMV, like the DC, Maryland and Virginia area, it is still, it's huge problem. And especially when you look at behavioral health options for people, for minors. That's even more challenging, especially if somebody needs, continued care. There are very few sites that provide it, let alone sites that take insurance, et cetera, et cetera. So that is a systemic problem. And so I just want to underscore the urgency of that, because the last thing that you need if you have a teenager in, and I can say this from experience, a teenager in, mental health distress is to be stuck in an ER for 3 days. So the other thing that I wanted to talk a little bit about the flip side of what this crisis looks like. And we were talking about a little bit last night at dinner, which is that because of the strain on ERs, people who are already admitted are at risk, become at risk of being sent home too early. We have talked about the issue of, sometimes it's the insurance that's saying, you got to take this person out because I'm not going to pay for another day. But there's also, in many cases, this kind of imperative to try to make beds available that then can have a negative effect on the patients who are already there. So I just wanted to I don't know if that was at all discussed in this meeting, but I think that it's important for us to remember that part of the sequela of that is challenges to patient care for people already in the hospital.
Thank you for that. Absolutely. It's come up in internal conversations, and I think I can't stress it enough. The experts here at ARC and our partners that have been putting this together really come from various backgrounds, and really are able to bring up some of the nuance, like you just pointed out. And absolutely, that's an aspect that's come up in discussions. Mm-hmm.
Yeah, thanks for that call, Alex. And I think it does underscore what I think, Sean, you did mention, which is it's not just an ED problem, right? So it really kind of goes throughout. You think about the flow and all of those things, and then you think about the, as he's saying, what are the community assets that might be available to kind of prevent the push into the ED in the first place, or slow that down. And then again, you going all the way through the hospital, and are there enough beds? And then you go into the rural areas, right? And then do you have enough? So it really is a systemic problem. So it happens to manifest itself as ED, overcrowding, but it actually, it's a pretty systemic problem. So it's a good way to start to address and attack what is a systemic problem. That's great. Peter.
Yeah, thank you so much. Great report outs. The overcrowding issue has been around for decades, and it's not a simple and easy solution. I guess 2 points. One, have we got enough different types of entities involved in sort of a consortia strategy? It's fine to have these kinds of conversations, and others in the federal agencies, as well as in some of the professional societies, have had similar conversations over time. But with the complexity of it, I think part of the call to action is, if you will, is to have a broader base of consortia activities, have that so there are substantive outputs from those consortia activities, not just another report that pops out. And I think this particular report has the opportunity to call that type of activity as well. And then to Cincy's comment, it's not just the negative impact of care on those in the hospital. We know that there are a variety of for-profit entities trying to tap into healthcare delivery and supposedly augment patient care. But within the general population, there is a hesitancy to go to emergency departments because there's awareness that I don't want to go and sit in that emergency department for 8, 12, 14 hours before I even get seen. So part of this is how do we capture data on the unintended consequences of delayed care? And we need to bring that forward as well as we bring this to the voice of our change processes. So thank you so much and great work so far.
Yeah, good call out on that as well. It reminds me of the consequences of delaying your cancer screening through COVID, for example, right? And the sequelae of that are just coming through even now, will continue to manifest themselves, right? So what is that? We're probably seeing a lot of that manifestation of the folks who should have gone to the ED but didn't, right? That'll continue to come through as well. Good call out. But
Peter, I just wanted to point out too that we're taking that next step in patient safety work and to really look at that what's now called diagnostic error, which captures this notion of a delay in diagnosis, not only just misdiagnosis as the term sometimes gets thought about, but it's really looking at that entire issue of timeliness that is part of quality care. And as many of you know, I talk about quality and its 6 dimensions, and timeliness is the one that always seems to not get enough attention.
Gina?
Hi, thank you so much for that review. One thing that I would just like to call out, if it hasn't been reviewed, is looking at alternative sites of care, such as hospital at home, ED at home, especially in those rural areas where ER facilities may be closing down or there's a challenge for access. Looking at alternative sites of care also could be an interesting and effective alternative.
Thank you. Carrie?
Maybe you can borrow another one.
Yeah, we're just moving on from Michael.
Thank you. Great. I just wanted to ask about the ED boarding discussion. You know, we're required in training to learn to deliver babies and to take care of kiddos, even though we may not do that in our medical careers, but we're not required to do any geriatric training. And I saw on your your social media cartoon that older adults were in the middle, and it said that often the older adults were included in the ED, boarding issue. And so I wondered if there was discussion about threading geriatric training through the ED and to our hospitalists and those who are engaged in the care of medically complex older adults.
Older adults were certainly present throughout the summit and in conversation. And even personally, I've had my own experience with older adults in the emergency department. It was a central point of discussion, I think, throughout the summit. And I think the staff at ARC and others certainly have brought up the need for a training in a variety of different areas. I know that there are many initiatives here that really focus on our older populations, particularly as we see the shift that's happening right now in the US. I do believe that came up in some of our sessions. I'd have to double check, but I've heard those conversations around certainly before. And if not, I'd like the other recommendations. I appreciate it.
Thanks again to Bob and Sean for these updates and highlights, and for to the NEC members for provocative questions and comments. Let's move on to our next agenda topic here. We'll bring up Tess Miller, who's Director for Center for Evidence and Practice Improvement. Tess is going to talk about the Patient-Centered Outcomes Research Trust Fund Extension Program. Mike is yours, Tess.
Thank you. I am delighted to be here this morning to give you an update on the ARCS Healthcare Extension Service Extension Program. And for once, I think I will have more details that might be more satisfying. Just as a reminder, the overarching goal of this initiative is really to accelerate the dissemination and implementation of new PCOR evidence or new innovation into the delivery of clinical care. And we're really hoping there to improve the quality of care within states, within healthcare delivery organizations, and most importantly, populations. We are focused on the safety net, or people who receive Medicaid, who are uninsured, and or other people who are medically underserved. And we're hoping to do this through evidence-based interventions and strategies that are focused at payment alignment, workforce issues, health information technology solutions, and of course, practice improvement efforts. We're also looking to try to coordinate activities in the state so that they can provide multi-level interventions to improve care. There are three components to ARC's Healthcare Extension Service Program. At the top box, or circle rather, are the state-based cooperatives. They really are the heart of this program. And as you can read in our notices of funding opportunities, each cooperative will conduct an initial intervention that is focused on behavioral health. We've left the definition very broad of what we're including and allowing applicants to look at as behavioral health. And they really have to provide activities around three cores. The first core is engagement, training, education, and assistance. And hopefully in that core, you will see the ability and the necessity of the cooperative to reach out locally and bring information from the local experience back to the state level so that they can all align and focus and bring in the local community voice back to policy and other possible solutions. They also will have a monitoring, feedback, and evaluation core. So we don't want to wait 5 years to find out like, oh, that didn't work. We're hoping that they will be continually monitoring their own project, bringing that back to both the state level, local level to understand, okay, how can we address this barrier that we've already learned about? And lastly, there will be an administrative core. And I think the most important piece there is that is where we are asking the cooperative to bring together a multi-stakeholder council. And that is at the state level. And they need to really bring the people together in the state who can make an impact on the policy levels and the different payment, workforce, technology, and practice improvement that they're focused on. So we've also left that very flexible because we understand that each state is unique and the group of people they need to bring to the table may vary. So we did require certain participants on the multi-stakeholder council, but then there's a wide range that we said this could also include. So you can see those details. The next component, the circle to my left, is the National Coordinating Center. And what we're really hoping that the National Coordinating Center will do is to support the cooperatives and continue to the overall goal of the project by providing technical assistance to the cooperatives, and that could be a wide range of assistance. It could focus on governance of the multi-stakeholder council down to policy, how to potentially work on a Medicaid waiver, and also quality improvements efforts at the practice level. They're also going to be developing and supporting learning networks. So for sure, we will have one that is a learning network of all the cooperative directors or PIs. Co-PI is the leadership of the cooperative so that they can learn from each other and hopefully accelerate learning as they address barriers in their own states. And lastly, the National Coordinating Center will also help with communication and dissemination. Again, we don't want to wait 5 years to find out what's working. We want to make sure that that gets disseminated as quickly as we can. And lastly, the circle on the right, my right, is the National Evaluation Center. So we would not be ARC if we did not conduct rigorous evaluations of this entire program so that we can learn more from how to do this and how to do this better. And the National Evaluation Center will conduct a rigorous multi-method rapid cycle formative and summative evaluation of the entire project. And we are looking for the National Evaluation Center to assess how healthcare extension services vary across cooperatives, Assess the range, reach, effectiveness, and quality of each of these models, and identify contextual factors associated with success. So really, it is a whole look at this initiative. So we've included the actual links to the NOFOs. You can read all the details there, but the team was very busy in September getting all three of these finally released. And you can see here that the first applications will be coming in for the National Coordinating Center and the National Evaluation Center. Both are due on December 13th, and the applications for cooperatives are due in January. We wanted to give you a sense of, just as Dr. Valdez said, we've been getting a lot of interest and excitement about this project. The team did host technical assistance webinars to give applicants an idea where ARC is putting emphasis in these requirements. And so we held 3 different ones. The state-based cooperative was towards the end of September. 425 people registered and approximately 280 attended. And they did represent, sorry, Bob, 49 states. The District of Columbia, Guam, Puerto Rico, and the US Virgin Islands. This is really, in my experience in ARC with NOFOs, this was a tremendous number of people interested in attending and who attended the technical assistance call. We also had technical assistance calls for the National Coordinating Center and National Evaluation Center, and about 90 people attended the National Coordinating Center and 74 attended the National Evaluation Center. One reason that may be is we anticipate awarding 1 award each for the National Coordinating Center and the National Evaluation Center. So given that we're looking to fund 1, that was also a tremendous response. I should also tell you, just to give you a sense of the size, each cooperative, we are anticipating awarding 15 cooperatives to start. Each cooperative will potentially receive $25 million over 5 years. We are allowing applicants to vary the budget by year somewhat. There's not a whole huge range, but they can budget different for each year. The National Coordinating Center will receive $14.25 million over 5 years, 1 award. They also may vary their budget by year, and the National Evaluation Center will receive $14.8 million over 5 years. I really also wanted to draw your attention to the bottom of the slide. We have a lot of resources publicly available. So the slides from the technical assistance calls, a recording of the calls, frequently asked questions that we are updating as we receive them. So if you're interested in looking at any of those, that link at the bottom will take you to those resources. We also created a page of additional resources for interested applicants that just has some reminders. You need to have created accounts in NIH, which can take you 6 weeks. So we've tried to highlight things like that, just tips to make sure that they can apply. And then we have resources from our other work that we thought would be useful. There's a how-to guide on creating state-based cooperatives from our learnings from our state-based capacity Evidence Now project. So we've posted that. So we've tried to give applicants some resources that may help them in the development of their applications. So just to give you a flavor of some of the questions we're getting a lot of nuts and bolts questions for how to apply, which is good. But also the multi-state question has come up a lot. We are not allowing multi-state applications, or to put that in a slightly different way, cooperatives that are going to plan and actively work in more than 1 state. That is based from our learning from our Evidence Now projects, because the regulation can differ so much by state. We really do think the cooperative working in 1 state where that regulation is what they need to concentrate on makes very good sense. And we've learned regional cooperatives really struggle. Yes, they might be next to each other, but their regulations could be radically different. As I mentioned previously, we are permitting applications from Washington, D.C. or any of the U.S. territories. We've gotten interest from all of them, so we'll see. Potential applicants have expressed interest in a broad range of behavioral health topics. So we've been conducting technical assistance calls with anyone who requests one, and we've heard a variety of age groups, focus of the actual behavioral health. So it's really will be exciting to see what kind of mix we get in the topic areas as well as age groups. And lastly, applicants have expressed plans to form and strengthen partnerships. So they have a lot of questions for us, like, can we do this with these people in our state? And I think often the answer is yes, that's what we're really looking for. We've also during this time been doing some targeted outreach to partners. So we have been meeting with some of our federal sister agencies, staff from those agencies, to really talk about, we do not intend to duplicate efforts, but align efforts. So hopefully having them on board both to join a federal partner work group, but also really thinking and for us to understand what is already in some states, what are they providing and how could the cooperative take advantage of that so we're not duplicating those efforts. This is the current team, and I would be happy to take any questions. Again, all the details, the links to the NOFOs are probably the best place to look to understand what is a requirement. The word must often signals that. So an applicant must, if you look at what comes after that, those are things they are required to do.
Outstanding. There's yeah, there these grant these applications are great. There's a great opportunity here with kind of really thinking about the state-based approach. There's a lot of work that's already happening in a lot of places, right? So how do you coalesce around some of that work and some of those partnerships that are happening at the state-based level? And there's definitely some opportunities from an evaluation or coordinating center. I could think of some right now that probably should be in this. If they weren't on that call, they should have been on that call. So really looks like great opportunities here. Looking at, let's take a couple questions here. So Kamal, you're up first.
Thank you, Dr. Miller, for that overview and update. Certainly it did stick out to me also the sort of enthusiasm on the calls. And I'm wondering, as more and more is being learned about the state collaboratives in the future, that will inform other funding. But I guess I'm curious, are there any learnings that can help, sort of inform ARC activities or funding opportunities, even just sort of seeing how much enthusiasm there is for this area?
Well, certainly a lot of the design of this was based on our learnings from several Evidence Now initiatives and other work we've done to really transform care. And absolutely, I think our intent, and as I mentioned, we are really hoping to monitor and assess and evaluate as we go. So we're not waiting 5 years to find out what worked, but we will apply those learnings. Another reason we think it's very important to create a learning community among the cooperatives so that states can learn from each other. So I think there are built-in ways that we'll be learning as we go.
Sure.
It is certainly my hope, and I believe Dr. Valdez's hope, that we will be able to have a second generation of the healthcare extension service, really based on what we learn from this one. And again, I think what we are really trying to capture is, each state is going to go about this in slightly different ways. And so to better understand what works in what kind of context, state context, as well as local context, I think will be critical for moving this forward.
Thank you, Dr. Miller. Are you planning on sharing, as you mentioned, there is prior experience that helped inform this NOFO. Those learnings, are they available to perhaps other funding agencies, other foundations? Because it really seems like there's something delightful here that's worth sharing.
I love the word delightful. It is delightful. And we have learned a lot. And I love your ideas about how to disseminate some of the materials that we have from our previous work. For example, on the page to assist applicants, we recently we had a final meeting for our Building State Capacity grantees, which was really fabulous, diverse group of people at the table as well as the grantees. So we put those findings as a resource to applicants. So figuring out how we can better share the messages that came out of that. I'd love any thoughts you have on really getting the word out, because yes, it is publicly available. We would love for people to learn from our experience and build on it and do it better.
Thank you so much for this presentation. I'm really tickled. My grandfather back in the day ran one of the agricultural extensions in Puerto Rico, and he would just be giggling to see how this is being extended beyond agriculture. But I wanted to first of all really thank you for, I did a very, very quick scan of the NOFO right now, to really thank you for making patient and family and community representation required in this NOFO. That is enormously important, and we're really grateful for that. I did want to ask two questions. In the evaluation process in terms of determining which 15 states get this grant, to what extent are you considering focus not just on, you know, the behavioral health, obviously, but on initiatives that would try to target communities that are facing real deep gaps and inequities, such as, you know, race, ethnicity, SOGI? How important kind of is that in your kind of analysis of who's gonna get the funds? And second of all, are you in the evaluation cycle, the quick evaluation cycle? Is there a plan to look at the data by, again, stratified by race and ethnicity?
So I know the NOFOs are pretty dense, but if you scroll almost to the bottom, you can see the review criteria. And so I believe all the things that you mentioned, we have included in what the independent panel, we will have a special emphasis panel reviewing these, but what they're being asked to look at and to evaluate. So people do need to make the case of they are working with in medically underserved areas in their state with medically underserved populations. They need to describe those. So I think that we've included all those review criteria, but I'd love if you take a look and say, hey, you know, something's missing here. Also, in terms of the evaluation, yes, granted, the national evaluation will propose the approach that it's going to use, and that will be reviewed. But again, considerations of, I think, everything that you mentioned are part of the review criteria for the national evaluation team as well.
Sharon?
Hi, this is great work. I love learning systems and how we can learn from each other. I'm curious if you've thought about how patient safety organizations could be involved in this as well, because there are state-based ones, and, you know, as patient safety organizations are working on their learning programs and how to enhance their programs, it's something that's already out there.
We did think about it, and we've had some questions from QIOs, for example, that could they come in as a potential cooperative. And as long as they can either themselves or better yet partner with people in the state, the answer is yes. They could come in as a cooperative. So we're going to wait and see. I can't tell you for sure, but they are certainly eligible.
Great, thank you.
Michael?
Thank you. It's a very exciting program. I'm wondering what you do about metropolitan areas, right? So you have an extension system for DC, but of course, Maryland, Virginia, Philadelphia, you've got New Jersey, Boston, you've got, right? So how do you kind of build in the fact that, you know, the care that someone gets in Rockville is not really going to be what they get in Baltimore? And how do you build in that kind of regionality?
Well, we had a lot of discussions on the team about could someone come in just representing a region? And you still had to be within a state, but could it be a region within a state? And we finally did say yes, but we did put a qualifier in there that they might start working in a subsection or sub region of a state, but our intent is that they eventually are looking statewide. And that's, I think, because of we really want to bring together the people at the state level who can perhaps work on policies and things like that at the state level.
Well, I understand the state level, but you might want to even have them start with regional, like from the very start. It's silly to have Maryland start and ignore the regionality, or you know, Pennsylvania, things like that. Just from the beginning, kind of have them know the people from the neighboring catchment areas.
Right. Again, I think we were trying to be as broad as we could to incorporate all the different kind of unique situations you might find in a state. So they may very well, in the state of Pennsylvania, I grew up there, Philadelphia may come in saying we're going to work in the greater Philadelphia area, which now may include Lancaster, which is where I grew up, which used to be rural, is still fairly rural. So they could start regionally that way, but they do need to indicate they have intention to not just stay regional, if that helps. Yeah.
You know, it's an interesting point, Mike, because you said I spend a lot of time in and around Philly as well. But specifically in Delaware and Wilmington. And I would say that Wilmington, Delaware has more in common with Philly than it does with Southern Delaware.
Yep.
But you're crossing state lines at that point, right? So if you said greater Philadelphia area, you should probably include Wilmington. But now you're crossing state lines. So that can get potentially a little messy there.
Dr. Robinson, one of the reasons that we're focusing on the states is also because of the population and the role of the Medicaid programs. And as you know, Medicaid is state and territory. And so, you know, whatever legislative action goes on in Delaware, it doesn't mean a thing in Philadelphia.
No, quite familiar having sitting on the board of the University of Vermont, which you would think is Vermont focused, but also has upstate New York.
Right.
So yes, very familiar with with the changes and challenges there. So one thing I wanted to make sure that was clear, Tess, is that this should be dissemination of evidence around behavioral health specifically in this
For the
notebook.
first initiative.
Okay. Okay. Just a little
And
make sure.
again, we gave a very broad definition, like when we met with our colleagues at HRSA, I just happened to mention that obesity in our definition of behavioral health, if you wanted to work on reducing obesity, that would fit. And they kind of went, oh. So we're not taking a really, I'll use the word classic definition of behavioral health, but really made it a bit broader.
Gotcha. Joan.
Thank you. Of course, this is extremely exciting work. In addition to what you're accomplishing in terms of what the cooperatives will do and how this will change healthcare and offer information, I'm equally interested in the process of setting them up. I'm in Maryland working on a project related to the redesign of public health. Post-pandemic. And if you look at every state, they're probably looking at that in some way. And there's national assessment tools and national standards that you could follow, but they're really not adopted by all the states. And so people are kind of doing their own thing with it, which isn't necessarily a bad thing. But if everybody's working in a silo and you can't spread anything, I think we're at a disadvantage. So if there's a way to publish on the actual steps you're taking, the pitfalls, don't do this, do that, sort of, I think that's equally important for us.
Thank you so much. And Jay, sitting over there, is Jay Crossan is leading the evaluation team. And believe me, he has thought and included a lot about the process and just figuring out how the cooperatives are created, sustained, really, you know, how does that work? And I think another reason we're looking at a learning community across states is so that they can start sharing. Part of the evaluation too will have a component of trying to harmonize evaluation measures. And I think some of those we're going to try to ask that all cooperatives measure some aspects of actually the cooperative itself, or that process as you called it. So hopefully we'll be able to do that and get some harmonized measures. So we will be able to kind of say how things worked across the different states.
Carrie?
Yeah, and on that note, I'm struck by the number of applications you might have.
Yes.
And was hoping you could just comment on how you recruited reviewers and how you'll handle potentially the volume that you'll get, and dealing with just making sure that folks are equitable. Being from the middle of the country, we always feel very sad that many things don't get funded as equitably in our region of the country. So anyway, just was hoping you could educate us on how you're going to deal with all of those logistics.
And now I am stepping outside of my sphere of expertise. I wish I had someone from our OREP office and our study review, because they have that kind of down to fine art. We have already started talking to them about how many reviewers are we going to need, first of all. And you're right, volume is really going to dictate that. We have asked, but not required, for letters of intent. And those letters of intent, we've already gotten them in for the National Evaluation and National Coordinating Centers. We get them about a month before, so that gives us some idea of volume. Dr. Valdez gave us the challenge of he would like us to fund one application within each of the HHS regions. So we do have written in there that ARC has some ability to, for geographic and other reasons, potentially skip or, influence kind of the order of funding. It's limited. So the study reviewers, really, those scores are the most important kind of piece, but we can look, if we've got, I'm making this up, 10 applications in the Northeast, we may be able to say, oh, but we have none here. And for that reason, geographically and diverse, to increase the diversity, we might look at that application.
I thought I saw another hand, but then it disappeared. Okay, go ahead, Mary Beth.
So thank you. It is exciting. As you're looking at that harmonizing of data, I'm in Colorado, and so we have areas of urbanization and then really rural areas. So I certainly appreciate that you don't wish to cross line, even though we do reach quite a bit into Wyoming, which has a lot of rural healthcare. But in harmonizing that data, I guess what I'm hoping is that we look at the different types of providers associated with behavioral health and the diversity in those providers that may or may not be influenced by state regulations for those diversity of providers as we think about the quality of care and the safety of constituents receiving that care.
It is certainly our hope too, and hopefully applicants will come in with applications that are there. I should have mentioned each cooperative will do their own evaluation as well. So hopefully we will see that in their evaluation, that they're looking at different types of providers within their state that makes sense in their state context.
Perhaps the opportunity for understanding diversity of providers that provide equal quality of care to help break down some of those state by state and national regulations to try to reach more care for all.
Outstanding. Well, with that, I want to go ahead and close out this. Thank you very much, Tess and team, for that information and sharing those insights. Before we break, I do want to pull in one comment that came in from not from a NAC member, but that came from outside. From Sheila Maroney, who was commenting back on the ED overcrowding conversation that we were having earlier, who wrote, while ED overcrowding has been the focus of many initiatives and summits over the past 25 years, historically it was the discussion about the efficiency of inpatient flow as a key bottleneck. While that is still a factor, particularly as it relates to capacity for step-down services post-inpatient stay, what is promising about this effort that Sean had profiled is that it acknowledges and embraces the critical importance of community partners and community-based services, both upstream and downstream. Kudos. So I want to bring that in. With that, we will take a 46-minute break. We will be back sharp 1 o'clock Eastern. NAC members, please stay on Zoom. Just turn your videos off and be back. We will start at 1 p.m. Eastern, whether you are here or not. Thank you.
Pictures.
Oh yeah, I forgot about pictures. Yes. NAC members also, there's pictures somewhere out here. Like before you go to lunch, we'll go do pictures. Okay, thank you. Yes. Welcome back, everyone. Hope you enjoyed your lunch break, if that's how you decided to use your time. See, photos are done. Let's jump right into our next topic. So our next topic is the update on the National Action Alliance for Patient and Workforce Safety. So Craig and Jade, I think, are gonna take it, right? So it's your show.
Great, thank you, Edmundo. We're really excited to provide this update today. Many of you may remember that in November of 2023, we had a presentation by a subcommittee of the National Advisory Council by Lucy Savitz, providing recommendations for what ARC and more broadly HHS could do to support safety of patients and the healthcare workforce in hospitals across the US. And this was a result, obviously, of the increase in safety incidents that we saw at the height of the pandemic. In March of this year, we presented our plan to operationalize those recommendations. And so what we want to do today is share a progress update on what we've done over the last number of months and get your feedback on that, particularly feedback about next steps. We have been incredibly fortunate to have many staff leaders in our agency contribute to this National Action Alliance, both within our own center, within the offices and centers across the agency. And we've been incredibly fortunate to have many leaders and staff from sister agencies across HHS, the federal government more broadly, and private partners contribute as well. And I want to particularly acknowledge Jade Purdue-Pulley and Melissa Botnager, who are leading this initiative on behalf of ARC. So I'm going to pass it to Jade, who will begin the presentation.
Thank you, Craig.
Sorry, let me jump in real quick, Jade. So this is for the whole group. We're not getting enough volume for the folks who are not here physically. So pull your mics closer to your mouth when you're speaking, please. Thank you.
All right, can you hear me okay? Great. Just to add to what Craig has said, it's Craig and my great honor to be able to provide this update to you. But at the Center for Quality Improvement and Patient Safety here at ARC, we have a tremendous team that is completely dedicated to safety, dedicated their entire lives, and have contributed significantly to all of this work, but we've called very heavily on them for the National Action Alliance. So I just want to acknowledge them. Additionally, in the way that the National Action Alliance is structured, we work very closely with all of our federal partners. And just like the team at CEQIPS, each of our federal partners has an equivalent team, which we've also drawn heavily on. And so I would be remiss if we did not acknowledge the great talent that we have at our disposal. For the next 20 or so minutes, there are a few questions that we're going to be running on. The first three are what Craig and I hope to share with you, give you a broad overview of the National Action Alliance, or reacquaint you with that, and talk about some of our activities and accomplishments over the past year or so, and then talk about what the immediate future looks like in the next 6 to 12 months. But there are a few questions that we're very interested in hearing your thoughts on. What are your best insights and ideas for how to expand our reach to other settings of care? And you'll have a greater understanding of that soon. Who are other important partners to engage, and what do future affinity groups should we consider moving forward, or even other high priority areas that we should consider addressing through the National Action Alliance? I probably don't need to say this to this group, but why this work matters is about 1 in 20 patients suffer from preventable harm. As you've heard from Dr. Valdez and Dr. Umscheid, at the start of the pandemic, we began to see decreases in safety indicators, which was a clear indication that things were not moving in the right direction, and had to really get behind it very, very quickly. Of course, you all know this, that the healthcare delivery system is very complex, but is completely reliant upon the talent of our healthcare workforce. And we know that they are still recovering from the pandemic, but even prior to the pandemic, we're suffering with burnout, both from emotional burnout as well as what I like to term administrative burnout. And so the thing that I feel most proud about the National Action Alliance and the work of the National Advisory Council is just the recognition that this really is a full system, and so that we have to not only attend to the patients, but everyone who encounters the healthcare delivery system, whether they're providing care or receiving it. And we've been very incredibly
fortunate that patient and workforce safety is an important subject at the very highest levels of government. The Biden-Harris administration's commitment to equitably protect and expand America's access to quality healthcare has been paramount. Last year, the administration launched the National Action Alliance to build partnerships between federal agencies, private organizations, healthcare professionals, caregivers, and our very important patient advocates. In April, the president signed an executive order on increasing access to high quality care and supporting caregivers. And just this past summer, the administration announced $100 million to grow the nursing workforce and to set a minimum level of staff in nursing homes, in addition to a slate of actions to protect patient safety. The one thing that I was remiss in acknowledging on one of the earlier slides is given the complexity of our healthcare delivery system, there are so many things that go right. You know, we treat about roughly 1 billion people a year, and many of them have wonderful experiences with the healthcare delivery system, receive the care that they need to heal or appropriately diagnosed and get back to their lives, which is what we want. But our work, of course, at CQIPS is to really focus in on how we can reduce those areas of harm. And one of the things that Dr. Prabhakar, who is the assistant to the president for science and technology, said at our White House convening on World Patient Safety Day is that we've got to get after it. So I've been holding on to that thought and comment about how we think about our work for the next 6 to 12 months. Technology. It just, oh, the snooze. We can't see the snooze on here. Okay, here we go. Thank you. But just to recap a little bit about the trajectory that we've been on since really 2020, as you all probably know, there was a public-private group of experts that got together to develop the National Action Plan. This was work that was led by the Institute for Healthcare Improvement and in conjunction with AHRQ, and had about 35 or 40 public and private organizations that pulled together the National Action Plan that would determine our trajectory for patient safety. That was released in March of 2020. And I think we all remember what happened in March of 2020. So it did not get the play that everyone hoped that it would. So then fast forward to November of 2022, HHS Secretary Becerra had a call to action for us to refocus our efforts on safety, given those key safety data points that we had been monitoring. AHRQ immediately went to work in conjunction with our federal partners and issued a request for information where we really got a better understanding of what the current landscape looked like at that point in time. And then in March, asked the National Advisory Council to put forward a subcommittee that would be focused and help us figure out the direction that we would take. Over the course of that time, while we're meeting with the SNAC, we are also meeting with our many federal partners and organizing ourselves to get ready for whatever was to come. It's almost at the same time, the President's Council of Advisors on Science and Technology issued the PCAST issued a report entitled "A Transformational Effort on Patient Safety," and also made recommendations directly to the president about how to improve patient and workforce safety. What's important to note here is that report was considered by the SNAC in making their recommendations, and ultimately what was presented to the NAC in December of last year. The NAC unanimously approved the recommendations that were made by the SNAC, And I believe that later on today, you will be taking a vote to approve the report in its final state. Additionally, and I've already mentioned to you that for World Patient Safety Day just this past September, we had the White House Healthcare Safety Forum, and that really started the hard launch for the National Action Alliance. And the National Action Alliance really serves as an organization, alignment, and synergy creation across federal and private entities around these 5 aims that the SNAC put forward. The first is advancing organizational safety strategies using a safety self-assessment. It was very clear when the SNAC met that every organization was in a very different place in the recovery from the pandemic. And so it was time to just take a step back and make that overall assessment about where they were. Part of the work that the National Advisory Council has done is make available to anyone on their patient safety journey self-assessments. In fact, one that is included is one that is developed by the Institute for Healthcare Improvement, which was originally part of the National Action Plan released in 2020. So you're already beginning to see some of the synergies that are being created, making this easy for anyone who would like to focus in on their different safety issues, easy for them to do. The next is empowering the patient's voice and safety strategy, and don't think I need to say anything about that. But then third, supporting the healthcare workforce by making healthcare safer by design. Particularly excited about this aim because it really speaks to what we can do to simplify and utilize technology and the research that we have to make the system safer, more fail-safe for our healthcare providers. The fourth is supporting the healthcare workforce by strengthening safety competencies. And this was an acknowledgement by the SNAC that there was and is a tremendous amount of turnover within our healthcare delivery system. And so they wanted to double down on ensuring that there were safety competencies regardless of where people were in their career trajectory, and also recognizing that we needed to backfill many of these positions and that there would be a significant push to do so. And then finally, facilitating the learning and research network, which we are all a part of, but moving us towards the interim target of a 50% reduction in patient and workforce safety by 2026. So the SNAC felt it was really important to provide a measurable goal for us to work towards. But we fully recognize, and through our vision statement, which is safe care everywhere and zero preventable harm for all, that we have a much further way to go than just the 50% reduction. This next slide just talks about it shows you the structure that we're using. I've already mentioned our Federal Healthcare Safety Alliance, which are our federal partners, which we meet with. We all get together on a monthly basis. We've done some very intensive work together over the course of a couple of days to really think about and strategize how we use our collective resources very well, and develop the strategy for how we will make healthcare safer. I can't see. And then I've already mentioned the National Steering Committee, which is a group that is still co-led by the Institute for Healthcare Improvement and AHRQ, consisting of about 35 to 40 organizations that have a vested stake in patient safety. And then our healthcare community partners, which are inclusive of patient and family advocates, and then healthcare provider organizations. Now, the important thing to note here is that the SNAC said, as well as the PCAS, that this should be an all of society approach. And so where our historically the federal the federal response to safety has been focused in hospitals, though also in other areas, but largely in hospitals, is that it should include all settings of care. And this is something that we could use your insights about, because there are lots, it is a complex system, and there are many settings and different organizations that have a vested stake in there. And so how do we reach those in a fast and meaningful way? And again, all towards our target 50% reduction. This next slide is what we call our engine slide. And we'll start at the very bottom where we talk again about the baseline safety self-assessment. And so our work is really built upon what's happening at the patient bedside based on what the needs are. And the way that we've organized ourselves is to try to meet the needs of any organization, regardless of where they are. And here are some of the supports that we're providing. National webinars, and we've tried to build upon what we think are, or what we understand to be some of the top issues, like workforce burden, turnover, violence in the workplace, as examples. We are working with our partners like the QIO program, the PSOs, on different implementation initiatives, folks that are really working at the bedside. And then there is, we are very fortunate to have so many tools and resources, particularly that the federal government has pulled together, and we've organized those in a way that speak to the 4 foundational areas of the National Action Plan, which are culture, leadership, and governance, patient and family engagement, workforce safety, and the learning health system. We've also organized the tools and resources to be focused specifically on certain harms. So regardless of where an organization is in their safety journey, that they have this curated library of resources to help them move forward. We're offering different funding opportunities as the budget becomes available. And then importantly, we are in development on measures and safety dashboard, which again capitalizes on the investment that the government has already made in measures and puts them in one area, so that we as federal agencies, but also in the private sector, can make the most sense of the data that we have, and have that inform our programs and policy and trajectory of our work. And this is just an example of some of the tools and funding opportunities and implementation initiatives. The example here that we include is obviously an ARC one, but I would just like to highlight we have tools and resources from across the government on the website, including the CDC Impact Wellbeing Guide, the ONC Provider Burden Reduction, and OSHA Preventing Workplace Violence, among many others. And the alignment, as you would hear from Dr. Schreiber, is no coincidence. And so CMS, of course, released the patient safety structural measure, which was largely based on the 4 foundational areas of the National Action Plan, which aligns with the National Action Alliance and all of the work that we've done since. And in particular, the National Action Alliance speaks to Domain 3 in the culture of safety, where the hospital conducts a hospital-wide culture of safety survey and implements team communication training. And hospital participates in large-scale learning networks for patient safety, of which the National Action Alliance is considered one of those possibilities. And organizations can make that commitment. They can utilize a commitment that we have on the National Action Alliance website to share with their staff, to acknowledge the work that they're doing. And we continue to build this out so that we can make it more apparent about each individual organization's commitment to safety. But this is what that commitment looks like. Craig, can I turn to you for some info on the affinity groups?
Sure. I'm going to speak very quickly toward a couple initiatives that we've been working on over the last few months as part of the National Action Alliance. The first initiative, as Jade was saying, are affinity groups of experts that we formed. And we've done this specifically for two of the aims of the National Action Alliance so that we could get more expertise in how we should advance those aims. One of those aims is incorporating safety competencies into the healthcare workforce staff across healthcare settings. And the second affinity group that we've stood up is an affinity group around better engineering safety into practice. So I'll talk about each of these briefly. So for our safety competencies affinity group, what you'll notice on this slide is that the titles of the individuals who we've included and their affiliations really help you understand that we've drawn on experts from different professional organizations who are creating the trainings and the accreditation and the curriculums that physicians, nurses, healthcare executives, safety and quality professionals are using in their training. And we got this group together and we looked at all the different trainings and curriculums that these groups support to try and better understand what are the safety competencies that they're supporting. So this next slide shows part of the process that we've gone through with this affinity group. And what you'll see in the figure are some of the more common patient safety competencies that are reflected in the curriculums and trainings and documents that these professional organizations support. So you see things like leadership, governance, and culture are very often referenced and supported, whereas some other safety competencies such as systems thinking, human factors, workforce safety and well-being are less reflected in these curriculums. So this group right now is having a lot of crosstalk about strengths, gaps in their curriculums, and the goal is to help them strengthen the curriculums that they're offering to their professional groups. The second affinity group that we've stood up is around engineering safe practices. And you see from this wonderful group of national experts that have agreed to join this affinity group that we have representation from the American Nurses Association, industrial engineers, the American Hospital Association, health systems, human factors experts, architects, ECRI, Joint Commission, AMA, the American Society of Health System Pharmacists. So really all those groups who are central and are stakeholders in the importance of engineering safety into practice. And what we've learned from these groups and these experts to date is that there are specific categories where engineering safety into practice is particularly relevant. So for example, how do we incorporate human factors design principles into the physical environment, the organization of our clinical spaces, the electronic health records? How do we incorporate engineering safety into practice to optimize patient care during transitions? So what we're doing now is we're scouring the different federal resources we have, and we're trying to surface those tools that best address these different areas. And I'll give you one example. AHRQ over the last decade has invested in the Patient Safety Learning Lab program. And many of those grantees have produced toolkits as a result of their work. And many of those toolkits are relevant to this, such as how do you best organize an operating room or an emergency department. So these are the types of tools that we're working to surface in this effort. As Jade said earlier, we'd love to have your input into other affinity groups that we may want to stand up in this new fiscal year. One other set of initiatives that I want to talk about that we've been working on over the last number of months is standing up a national healthcare safety dashboard to really track our progress on safety and ensure that we're making progress over the years. And so this is a screenshot of the homepage of the dashboard that we're standing up, and it'll be available shortly. And I want to highlight two pieces of this dashboard. One is that the dashboard is not only focused on patient safety measures as you'd expect. So we have patient safety measures from AHRQ sources like patient safety indicators and CMS sources like safety measures that are part of their hospital reporting programs. But we also have measures reflecting healthcare worker perspectives on safety. So we have survey data from surveys on patient safety culture from hospitals across the US, which we're presenting. So that's the first characteristic that I want to highlight. The second characteristic is that this data is data that already exists, that institutions are already submitting, and it reflects data from not just ARC, but organizations across the federal government, including CMS on this first iteration, which focuses on hospitals, but other iterations will expand to include other environments like nursing homes, clinics, et cetera. This is a screenshot of one of the measures that we're capturing. It's a patient safety indicator, and it's looking at all payer death rate in low mortality diagnosis related groups. And you can see how we can track that measure over time. And for some of our data sets, like the patient safety indicators, we could even stratify those variables by important subgroups, like by race and ethnicity. And so this next slide shows you how we can do that. And so this allows us to track progress on safety over time across important subpopulations as well. So I'm going to pass it back to Jade.
We just wanted to take a few minutes to highlight some of the actions and accomplishments that, oops, sorry, we're sharing a camera. Thank you. Some of the actions and accomplishments that the National Action Alliance has observed. So recently, ARC released the first adverse event report since 2017. The CDC released the core elements of hospital diagnostic excellence. Of course, CMS releasing the patient safety structural measure. The ASTP, formerly ONC, recently updated their safer guidelines for electronic healthcare records. HRSA responded to the nurse shortage with nurse retention and workforce expansion programs. IHS has conducted the safety self-assessments across all of their facilities. And of course, we mentioned the PCAST report and the convening at the White House as well. A little bit about what the next 6 to 12 months may look like. So ARC will be conducting a best practices evaluation. We're in the process of identifying high-performing healthcare systems and/or high-performing hospitals to see what it is that's leading to their high performance based on available data that we have. ONC has recently released the safer guidelines, and they'll be hosting a webinar through the National Action Alliance in January. And of course, CMS will be beginning the data collection for the structural measure in January as well. NIOSH, through the CDC, will be hosting a webinar series on violence in the workplace. This will occur probably February, March, April. And then, of course, we have Patient Safety Week, where all of our agencies, as well as our federal partners, will have many ongoing activities related to that, and the CMS Quality Conference. CMS has kindly offered to host our federal partners as well, and so we will be using that time to convene again. And then the Veterans Health Administration, who's also been a wonderful partner in all of this, will be hosting their safety symposium. So that takes us through May. We are using World Patient Safety Day in 2025 as our target to remeasure ourselves, and we will be ARC will be hosting a research forum. This was a direct request made from the PCAST report, and so we'll be doing that in August or September of this coming year. For those of you who would like to see some of the things that we've talked about, the best place to get started is the National Action Alliance website, and it is on the landing page for arc.gov. Oops. And I see several hands up. Armando, do you want to go through the questions first, or should I pose questions to the group? We should pose questions. To the
Yeah,
group.
post
Do
the
you mind?
questions and then I'll pull people individually.
Very good. So we did want to just circle back around, and hopefully during this presentation, you've had an opportunity to think a little bit more about this. But what are some of your best insights and ideas for how to expand our reach to other settings of care or partners that we should be engaging? Another thought is future affinity groups that we should consider driving improvement, and then other high priority areas that we should consider addressing through the National Action Alliance.
And Edmundo, I've been asked to share one piece of information around that last bullet, high priority areas. So one thing that we did not speak about in our National Action Alliance presentation was the work that ARC is driving around AI and safety. And that is obviously one topic that you may be interested in discussing in the question and answer session. I did want to highlight that ARC has been working very closely with our partners across the federal government as well as private partners. And we've been working hand in glove with ASTP, the Assistant Secretary of Technology Policy, on the HHS AI strategic plan. In particular, we've been working on the section in that plan around AI and healthcare delivery. And I'll give you two quick examples of activities that ARC has been driving in that space over this last year. One is our center has worked very closely with our colleagues in the Digital Healthcare Research Division within ARC to stand up a new funding opportunity to robustly evaluate AI and the safety of AI in the context of real-world healthcare delivery. So that funding opportunity is now available. The next funding date is January. The second example I want to highlight is that Andrea Timoshenko, who leads our Patient Safety Organization division, has been leading an effort to leverage the safety event data that we've captured in our network of patient safety databases, which is part of the PSO program, to better understand and characterize safety events related to AI. And so there's findings from that work already on the Patient Safety Organization website. But I share that because one thing that may be particularly helpful for us as ARC as we move that AI and safety agenda forward is potentially getting further expertise from possibly a subcommittee of this National Advisory Council on how ARC can further advance safe use of AI in healthcare delivery. So I put that to the NAC.
Thanks, Jade and Craig. So let's take questions or comments, either addressing the bullet point questions on the slide, the last comment around a subcommittee of the National Advisory Council, or other comments as they have come to mind. Michael, you're up first. Red is
There,
good.
it stayed
Red
on.
is good.
Okay. All right. Thank you. So I thought what you're doing is very impressive. And I thought the SNAC report was terrific as well. I want to say a few critical words, but I want to do some level setting. I've been doing patient safety for 30 years, more than anybody else pretty much except Lucian Leap and Don Berwick. And I hate it. I hate the fact that this all still persists. And I wrote an article in 2003 called The Silence that ARC and CMS, which is an ICFA then responded to. If we really thought there were 100,000 people dying a year, how would we act? And in 1998, in fact, there was a Zero Preventive Harm initiative, the Jewish Healthcare Foundation did the Pittsburgh Regional Healthcare Initiative based on my book, and it didn't last as long as it should have. So you've got a great structure. If I'd asked this question, I'd be happy to work subcommittee. I've written about AI and all the rest of that. How would I get action when there hasn't been action? And the level setting is this. If you ask anybody in patient safety movement, what percentage of hospitals are committed to zero preventable harm? Say we have 5,000 acute care hospitals. And you say, are 5% committed to zero preventable harm? Do we have 250 hospitals in this country that are committed to zero preventable harm? almost inevitably, the people who really know laugh and say no immediately. No way. And yet the public doesn't realize this. And some of the people on your committee, on your steering committee, are the reason we don't have that. And some of those people are also the people who know that fact and don't do much about it because they're consultants. So how would I goose things if I really thought that, you know, the next person who died might be my mother, father, or friend or child? Or even it's been known to actually have doctors and health services researchers harmed by hospitals. Who knew? And so I work with the Blue Cross Blue Shield of Massachusetts when they had their alternative quality contract. And they had both a great big steering committee of very smart experts, many of whom were from Harvard, and you know, a kitchen cabinet. And I would suggest if I were going to do this and help you take a really thoughtful, impressive structure and move it more quickly, I would get a kitchen cabinet of people who've had some front lines experience with resistance and with overcoming resistance and with sort of, you know, moving things along. I would get someone like David Ballard, Dr. David Ballard, who used to be here on this committee, who did great work in Texas and also has been a consultant, knows this kind of stuff. I would get Ed Lofton, who is a nurse, senior executive in the Florida hospital that did wonderful work, one of the few hospitals, an independent hospital people don't know about. And I might get Stan Postotnik, who's a pharmacist and one of the early pioneers in Intermountain Healthcare, who was also an informatics guy and went on and did a lot of consulting and with the different detections kinds of things, and has been out there trying to sell it and knows that. People who've been doctor, nurse, pharmacist, front lines, consultants, to really help you move this along. Because we all know who've been in this movement, the problem is partly technical, but it's mostly a matter of will. I wrote something for Health Affairs Forefront in 2010, which I updated and is coming out in the American Journal of Medical Quality, called, in the kind of subtleness I try to make my specialty, Why We Still Kill Patients, Invisibility, Inertia, and Income. And the reason I wrote that is it really, really bothers me that good people, our friends, our colleagues, caring people are not as upset about this as we are. And they're not bad people. And yet the physician who stays up till 20 hours working on an individual patient may still be the same physician who doesn't want to buy a computerized system to help reduce, infections or whatever. And so the reasons that I looked at were the invisibility of it. Often people were sick, inertia that comes about for various reasons. And frankly, what's not talked about is income. And I've quoted the medical literature. There's little, allusions to this. You can see if the infectious disease. So you have done yeoman's work in a really comprehensive way, for which I commend you. I would start looking at the cultural and other barriers. Lastly, your dashboard there, the ARC Culture Survey is not very good. And the people who then report on it apparently were trained by ninth graders doing book reports. It's not very well reported on. It's not very well done. Something where you send out a survey every 2 years where you get to talk about what happened to you 2 years before that and then publish it in another year is not serious about people dying. It's simply not serious. And the way the thing is compiled is not serious. There's nothing more important than culture to change. And so I would just suggest to you that you look hard, because you all have been doing this a while, and really use behavioral science and politics and everything else to make sure you succeed, because it's a wonderful effort. So thank you.
Thank you.
Yeah, there were a lot of comments there, Michael, and I think it would be tough for us to respond to those, but I think we really appreciate those comments. The two quick things I'll say is I'm relatively new to government, and I've been in the quality and safety space for much less time than you have. But even in the short time I've been here, I have seen a dramatic evolution. I think one of the challenges is healthcare has also gotten a lot more complex and a lot more fragmented. So I think the risks are even higher now than they were 20 years ago. one thing that I've been really impressed with in my relatively short time at ARC is how well aligned our sister agencies have been and how well we've been able to work together. That's something I did not anticipate walking into this role, but have been really excited about and is one of the best parts of the job. I'd say the same is true for the big private partners we work with. And I think the more we can align with each other, I think the greater our success is. I wanted to make one quick comment about the patient safety culture survey. The data that we report on is data that's voluntarily reported to us after that data is collected. And most of the rubber meets the road at the actual organizations who are conducting those surveys, getting responses from their staff, and then acting on those responses. We're simply collecting that data that's already been collected and reporting on it nationally, just to keep track of our progress.
I understand that, and you guys are great. The rules of the survey, and I've confused this with the CMS, every 2 years, you can tell us anything you've done the other 2 years. So even if it's voluntary, and then the way your contractor reports it is dumb, that's the nice word. There's no storytelling, right? So I understand their constraints. Again, just have everybody think. I remember once a physician saying every doctor has 3 patients, their parent, their spouse, and their child. And it's a wonderful saying. And if we can keep that in mind for contractors reporting on data, that would be nice.
Oh,
Thank you. First, Craig and Jay, thank you for the presentation and information. A couple of things. I noticed that from the groups that it's very medicine and nursing heavy. So when you ask the question as to what other groups or what other affinities, I look at pharmacy, and pharmacy, one of the largest issues with the pharmacy workforce is patient interactions and just very violent, aggressive patients. And so one of the things that I say as you look at expanding outside of that, you mentioned AI and that digital space. I think getting into that retail setting or other community setting for pharmacy and other entities that are primary care, that's in that local community space is another. And then the other is that we're seeing is you see an increase of at-home care. Whether it's treatment therapy or whether it's just at-home diagnosis. And that's not addressed in this. And I can understand why resources and what have you, but that would be something else that I would say that I would look to see ARC getting into at some time in the future. And then I would love to serve on one of those affinity groups or in any way, in any capacity that I could assist from that aspect.
Thank you.
Yeah, that's really helpful. And the one comment I'll share is, I know, Al, in our discussions, there is a pharmacy or multiple pharmacy patient safety organizations. And I think thinking about how to address some of these issues in that retail pharmacy environment is not one that we've talked a lot about. So definitely appreciate that, that advice.
Shaji?
Okay, I had a question, a comment, and a proposal. My question has been answered multiple times already, so I won't ask it again. Basically, AI and patient safety, right? So the comment is that with new technology like AI, it's going to solve a lot of patient safety problems, but at the same time, it's going to produce new kinds of patient safety problems. And we all know, I don't want to spend time to elaborate, but we all know that with technology, especially black box, if we act on it, and there are a lot of things that we cannot predict today, right? So just a general comment that today the AI, we all know this is super important and change everything at very fast speed. And today we are, in my opinion, we are at a moment of James Watt during the Industrial Revolution. So AI is liberating all of us from a lot of cognitive tasks. It can do a lot of things for us at a much faster speed and at a scale and everything. So last night, after the dinner, and especially after 2 old-fashioned cocktails, and as a retiring LEC member, I thought I wanted to do something. So last night after the two cocktails, I took the liberty to wrote a proposal to establish the subcommittee on AI and patient safety for NAC. I think it's super important. And we have this because everything is changing so fast. We have to make use of expertise across the country to really help us to set the guardrails and the tools, the data to really do something about it. I think the opportunity is great and we cannot wait.
Yeah, I think that's great. We really appreciate that proposal.
Thanks. And what we'll do before I get to Joan, what we'll do is I want to carve some time in this Q&A component, which we've got 13 minutes left of, I believe. Yeah. To have that discussion. So I may not be able to get to all the comments, but I want to carve some time out so that we actually have dig into that a little bit more that Shaji just introduced. Joan, you're up.
Thank you. So this is one of my favorite topics, one of my many favorite topics, but this is way up there on the list. And your presentation was fantastic. Thank you. I love the work. I want to underscore, in my opinion and professional opinion, the human factors piece, and agree it's been undervalued and under incorporated into safety. I mean, in my mind's eye, I see it in the prevention phase, in the design phase, and also like an RCA without a human factors person in there is really lacking. So I want to throw that out there. I've grown to move away from thinking about patient safety and workplace safety to safety. And in my mind's eye, it's a Venn diagram with competencies in the middle related to prevention, intervention, RCA, and some competencies for each of those on the outside, whether it's for environmental design or patient, clinician, clinical work. But I think that approach is more comprehensive and it eliminates redundancy in some of the research, study, and intervention. So I think if we could think of it that way, teach it that way, think of competencies that way, there's some real synergy to be gotten from that. And as it relates to where to reach out next or more, so for all the years in my career, I railed against the idea in my mind that regulatory bodies have to tell us how to act because otherwise we don't know how to act. And when I started to get out there into the world of ambulatory care and saw the difference between regulated spaces like ASCs and everything else, I started to rethink my ambivalence on having to be told what to do. It's the wild, wild west out there when you go into practices and see what people are doing. I'm sure you all know stories that can make your hair fall out of your head from the things you see that people just think are okay and normal and whatever. So I think looking at the ambulatory care, especially non-regulated, I do agree with the home health. I mean, if you're a hospice person, you can't control if the person's going to put a slip rug by their bed so they can fall the minute so how do we figure that stuff out? And I always believed in the idea of more stringent safety considerations in the IT world, even before AI was involved. And now I think that's on steroids too. So thank you. And thank you for allowing 5 comments in one.
And I want to push and second that IT comment. I want to expand it to really thinking about all of the vendors that kind of service the healthcare system, right? So IT for sure. We've got a lot of these third-party vendors, and they may not be holding up the standards, right? So it's in, obviously there's technology pieces, there's the hardware, and the software. There's all these other parts and pieces that have to tie in. We think about it in cybersecurity, for example, right? We have some criteria around cyber, but do we do the same thing around the rest of our safety culture and hold them to the same accountability that we really should be holding the whole system? So I like that point, and there may be something there to dig into Craig and Jade. Sunil.
Great. Craig and Jade, thank you so much for your excellent update on this work and for everything that you and your partners are doing. I have two comments. One is around your question about additional sites of care. I can't even keep up with all the different ways in which we're delivering care now. Whether it's telehealth provision of specialty consult services, telehealth from a traditional brick and mortar office to a patient saying, I want a drug and I'm going to use this third-party service that I know will prescribe it for me in a one-time visit. Hospital at home. There's a comment in the chat about street medicine as another venue. So there are many, many different settings where we may not have an ability right now to collect safety information. And so I think incorporating all those as part of the national work is going to be very important. That can relate to both patient and workplace safety for those providers in those settings. If we think about people going into the home, there's issues of aggressive pets, firearms, and things like that we just fortunately don't have to deal with as hospitalists. The second comment is around the dashboard that you're building, which is really wonderful. One concern that lingered with me from a prior NAC meeting was our tendency to overlook groups that are small in number when we're stratifying. And it came up in the context of our discussion on American Indians and Alaskan Natives. So as you're looking at different strata for safety reporting, if there's an opportunity to use the power of aggregated data to enable a drill down into groups that are inherently only 0.5% or 1% of a given healthcare institution's population, so that they too are represented in some of the cuts that we're doing, I think that could be really powerful.
Thanks, Sunil. So at this point, I know I see like a few more hands up, but I do want to pivot the conversation because we have essentially kind of a proposal on the table that both kind of got initiated by Craig, but also Jaji after his 2 cocktails dug into. So really I want to kind of get the conversation, and again, I know that there's more comments, but get the conversation to whether or, kind of not just whether or not we should vote to commission a SNAC, a subcommittee of the National Advisory Council, but also if we want to explore that, what's the charge? What are we asking this subcommittee to do? And kind of what are the parameters and scope around their activity? So I'm going to kind of reset our questions there. So if you raise your hands, that's you're speaking to those comments. So that ultimately we're going to have to we may want to take this to a vote if someone proposes that we take this to a vote. So I want to shift over to that part of the conversation. And with that, who I see on my list is Michelle first.
So thank you. And yes, I had other comments, but if you want to talk about AI, I think it's a great idea. I would only caveat that there's a lot of work on AI going on across the government space, including HHS. And before commissioning an AHRQ sort of specific conversation around that, I personally would recommend that we look across HHS and even other federal partners. ASTP, I think, is already leading things on AI. HHS is leading things on AI. I can go on. CMS is leading things on AI. And so unless there's something very specific for ARC to maybe research, and even then I would sort of see what's going on in the landscape before commissioning a committee, because even part of the Cancer Moonshot, we had several sort of sub projects on AI. And so I think to the degree that we can align, you guys have aligned so well around patient safety. I think AI needs to be aligned and clear of what's needed before you have another task force.
Can I make a quick comment?
My only comment.
Yeah, what we were talking about is subcommittee on AI and patient safety with a focus on patient safety.
But even that, ASTP is already looking at that. And so do I think it's a terrific idea? Absolutely. but I think it probably has to be aligned and part of a broader conversation too, would be my only
And
point.
just to add a bit more detail, one of the things that we've been talking about internally is as we get some of these proposals, research proposals in response to our funding opportunity, we are looking for even further expertise around how do you robustly evaluate studies examining the safety of generative and predictive AI. So that would likely be one important question that would be ARC specific, ARC relevant that we'd want addressed. And then the other question might be informing an upcoming session in a NAC meeting, perhaps in the spring, around how ARC can further drive safe AI in healthcare delivery through research and dissemination. I think those would be our two asks.
Thanks for that, Craig. I think the point though is well taken from Michelle that given the amount of activity across even just the department, much less maybe going outside the department in this space, it would be probably worthwhile, given the resources necessary to conduct a SNAC, to at a minimum explore what else is happening and be very distinct about what niche this SNAC would be filling, what gap it would be identifying that it's addressing, and so that the NAC would understand that you actually are being complementary to the other activities and tying into those other activities. Or you can come back and say, you know what, the things that we're talking about are already being covered. We're just going to latch on to that, and we're gonna find a way to jump on to the activity that's already happening. I think that's worth an exploration. Michael, I still have your hand up.
Just quickly, and I agree with Michelle's point as well. So when doctors write about the safety of AI, and as I read the journals, what they typically mean is, will AI provide misleading clinical information to clinicians who are using it or to patients, right? The second factor about AI and patient safety is, which is not written about as much, which I understand with the LLM, is will clinicians adopt AI that makes care safer, such as the Bayesian health stuff that Sushi Surya is doing and others. And so doctors like to talk about how they're going to be misled, but there's a whole balance, autonomy and accountability. AI can also lead them where they haven't been willing to go before. So we have to look at this. And then there's the third element, which goes beyond the LLMs, which is the capability of AI to make care safer by giving information to patients that they did not previously have. And this has not been written about, but I'll give you the example. Some of you may be familiar with something at Stanford called the Green Button Project, where Stanford did use natural language processing, machine learning to mine their own outcomes, right? So it's not an LLM hallucinating. And that's then being spun off into a company called Atropro. So one of the people involved with that, Nigam Shah, who's chief digital officer there, patient at his own facility. He goes in and his doctor recommends an endoscopy. And he uses the green button to look at his own institution's outcomes for safety, infections, whether it finds cancer, et cetera. This is fairly revolutionary stuff. And if we are looking ahead with the use of AI, having performance information that's personalized, if for men of such and such an age, blah, 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 right, over the last 5 years, then we should be looking at the potential of LLM or machine learning, right, to improve safety by real-time performance data. And you also know that Epic's got something, Cosmos, with its 4,000 zillion patient encounters that they're trying to do. And again, I know that all of the agencies are looking at this, but if we look at safety and AI, I think we should look at it for those three prongs, not one, to ensure that we're looking at it from essentially a public policy point of view, as opposed to a narrower clinical point of view.
Thanks, Michael. So again, we're focus on the snack. Was your recommendation on the snack to follow Michelle's recommendation, or how was your?
You summarized it well, and you did a great job of having a group to look and see, should we, don't tread because things are happening too quickly and being published, or whether there's a subset. So I think doing a small exploratory without deciding in advance one way or the other, I think that was your own suggestion, Mr. Chairman, I think was the best.
Okay, fair. I make no assumptions about that. So that's why you all are here. So I appreciate that. So with that, we'll close out the discussion. The prevailing sentiment that I'm sensing, unless you tell me otherwise, is that we would task staff to explore where specifically a snack would add value to this conversation. Not that we don't think this conversation and this exploration is valuable; it's highly valuable. But we want to make sure that we are focused in the areas where we think more specifically that there's a gap that we should be addressing with a snack. That's what I'm hearing. Okay, very good. With that, are we good?
I think there's one more item.
Oh, no, we do have to vote to accept the report. And so do I hear a motion to accept the report as given? Been moved and seconded. All those in favor say aye. Anyone opposed? That report is accepted. Thank you.
Thank
Craig
you.
and Jade.
Thank you.
All right, with that, we will jump right in. We are 3 minutes behind. So we will jump right into our update on CAPS vision and strategy with I think Laura and Karen. Yes.
Slides. Oh, there we go. Okay, perfect. Good afternoon, everyone. Oh, Red, thank you. I am delighted to be here today and to see you all awake and full of great ideas and thoughts. I'm joined today by the ARCS CAP team in person and on Zoom. We have Karen Chavez, who is here to my left and directs the division that has the CAPS program. So she oversees it. We have John Backdash, Aruna Josti, Siobhan Edwards, and of course, Craig Umscheid and Aaron Grace. What we're going to do today is talk a little bit about the history and current work of CAPS. We've done some of that in prior NACs, but we wanted to do a quick review for everyone, just a little bit of level setting, and especially those new to the conversation. And I'm going to turn now to Karen Chavez.
Great. All right. So to do a quick refresher, the next few slides, next hopefully less than 10 minutes, I'll spend reviewing what we have discussed in previous NAC meetings, but just to get everybody on the same page. The program started in 1995. That was almost 30 years ago. During this time, this was the rise of managed care organizations and growing emphasis on patient engagement in health services research. As you all know, with this program, ARC established a new standard for engaging patients and stakeholders in research. The CAPS program focused to objectively measure patient experience as a way to assess quality of care. By quality of care, meaning getting the right care at the right time, most simply, from the patient or consumer's perspective. This brings us to the design principles, which is really important to understand, fundamental to CAP's work. The surveys are about asking patients about what's important to them and can only be provided by the patients themselves. They're the only source of that information. The survey questions are understood and interpreted consistently across all different kinds of patients and consumers. The surveys help us understand how healthcare is delivered. And lastly, surveys are administered in a standardized manner. Now, it's also important to understand the roles of our major partners in our activities. I'm going to talk a little bit more in detail in the next few slides, but overview, high-level overview. At ARC, the CAPS program is the basic research, and the members of the CAPS consortium are integral to that. We continue to support research and explore and refine survey methodologies for emerging topics and in new settings of care, and much more. In the middle are our survey sponsors, CMS, DOD, VA, our other federal sponsors. While ARC is not a regulatory agency, we do work with these agencies who have regulatory functions. Any requirements for the use of CAPS surveys and data to be reported come from these other agencies. On the right are our survey vendors who are hired by hospitals and healthcare organizations to administer CAPS surveys and to analyze and report results. As we consider the future direction of the CAPS program at ARC, each of these roles in research, administration, implementation, have an impact on healthcare policy and delivery, and that needs to be considered. A quick refresher on all the different kinds of CAPS surveys available. Most of you are familiar with hospital CAPS, most likely. There are other facility-based CAPS surveys, such as for nursing homes and dialysis centers. You may be a little bit less familiar with some of the other CAPS surveys that are condition-specific, like cancer care CAPS, or the newest one on mental health care. But there are a number of other health plan CAPS, dental plans, and also home and community-based services, as well as our clinician and group CAPS, just to name a few. How CAPS surveys are used, most obviously in quality improvement. Healthcare organizations have a suite of tools, including CAPS surveys, that are for their quality improvement initiatives. Public reporting is another way that CAPS surveys are used. Survey sponsors use data from CAPS surveys for consumer ratings. They use data from the quality measures based on CAPS surveys for benchmarking. CAPS surveys are also used in certification. NCQA is a sponsor that uses CAPS surveys for accreditation, for example. For value-based purchasing, as a survey sponsor and healthcare payer, some CMS programs rely on CAPS surveys for these initiatives. And lastly, CAPS surveys are used for health services research. Last time I checked, there are about 500 plus publications related to our program. Now, some of the other work at our agency in CAPS is not just about the surveys, but resources and tools that extend the value of our research. We provide technical assistance. We maintain voluntary databases. And for some of these, organizations can submit their survey and get their own feedback report based on analysis of the data. ARC also produces a quarterly series of webinars on CAPS and research. We conduct an annual CAPS research meeting, which brings together our survey partners, stakeholders, and researchers to share the latest findings, evidence, and innovations. And these are all accessible online from our CAPS website. I'll end here with this is the overview of our latest activities, research done by our CAPS consortium. I'll mention just a few here. The outpatient mental health survey was just released in June. There is one planned for inpatient mental health care as well. Another survey in development is the childbirth survey in hospital settings. We have ongoing work on patient experience, on increasing response rates and representativeness of the surveys, and as well as on patient narrative reporting, new questions on perceived bias and discrimination, and more. So with that, I will turn it over to Laura for the next part of our discussion on your feedback.
Great. Thank you. So we know CAPS was and is. Thank you. We know CAPS was and is valuable. Karen has just discussed a few of the highlights. However, we have heard calls for thinking broadly about the future. And these calls have come from you as well as others. We are very appreciative of the NAC attention, ideas, and suggestions. We've also talked with others informally over the last 2 years, as you can see here. We've got a list of various people in government, a lot of CMS, as they are an incredibly important partner with us in this work, but as well as other areas throughout the government, multiple professional organizations, including policy organizations, as well as patient organizations. This listening tour has given us a lot to consider for this groundbreaking, but now 30-year-old program. And as an aside, my husband and I bought a 30-year-old house a few years ago. It was lovely, but definitely also needed some updates. And we know that CAPS, built as it is on a strong foundation, is like any 30-year-old house. It needs fresh eyes and improvements. We don't want to tear it down, but it definitely is time for a new roof and some insulation. How about some new windows, and maybe the bathrooms need some updating. At least these were the things we looked at in our house. So this listening tour was a little bit like a house inspection to give us a broad idea of the various concerns and suggestions, both for iterative improvements and possible larger scale changes. So what did we hear? What have we learned? This is not an exhaustive list, but to give us a flavor of the areas in which we might focus improvements. We heard a lot of concerns about survey specifics, and I'm going to go through those in the next couple slides. We heard about a lot of confusion in the field about the role of AHRQ, CMS, and vendors. Karen spoke a bit about that today, about whether we're measuring patient experience or satisfaction or a patient-reported outcome, about any relationship of CAPS to patient safety. We heard a lack of awareness about CAPS, its importance, its use, and its name. Even my own family is confused. So we heard limited knowledge about the substantial 30-year research base, including association of CAPS measures with outcomes outside of patient experience, and the best administration modes for patient groups. And we heard uneven awareness and use of narrative items. So in terms of the specifics, in survey implementation, we heard concerns about sampling requirements, survey modes, response rates, representativeness, the time lag between visits and results, and how it can be administered in a more cost-effective way, both administration, but also analysis of the results of the survey. And then survey development. We heard calls to re-examine foundational development principles, to confirm that the surveys today focus on areas that patients find important, to consider the relational aspects of care, such as trust, dignity, respect, and bias. How can we shorten the timeline to develop new surveys and to update existing surveys? What about reducing the length and complexity of surveys? And then there are those areas in the surveys that have limited differentiation or are topped out. In other words, people all perform well, so they can't really do quality improvement on it, and people who are using it for accountability can't discriminate between different groups because everybody does well. And then subspecialists, we hear, don't recognize themselves in the survey. So should we develop items that are applicable to subspecialist practice? And then assuring that the surveys are built for the for the purpose that they're being used, whether it's quality improvement, accountability, reporting, payment, as you heard Karen describe. So these are all areas in which we have heard a call to do deep dives and work on solving these concerns. We heard this is coming from the heart, that people really value patient experience and want to use the surveys, but would like us to solve the problems that they encounter frequently. And we agree, these are important. Some of these are known challenges, not new, but it's time to solve them. So based on the listening tour, as well as what we've observed was critical to the work, we developed this vision and principles. And we think this is really consistent with those underpinning CAPS currently, but also new, and we think could take CAPS forward into the next 30 years. And hewing to this vision, we think we can work to address the concerns we've heard on the listening tour and want to talk now about what we think the work ahead might involve. So just to go over the guiding principles and vision, the vision being all care is patient-centered. Patients are partners in survey development and improvement, that we ensure equity in measurement and improvement, and specifically that CAPS surveys are meaningful to patients and minimally burdensome, robust instruments for quality improvement and accountability, that we have a systematic process for feedback and continuous quality improvement, and that CAPS evolves with changes in care and with patients' needs. So as the times change. We've identified a number of ideas we would like to explore, as shown here and on the next slide. And we will likely generate others as we go deeper, but certainly a direct patient connection seems very important. We are familiar with the PCORI participatory research model that they announced earlier this year and think that is worth exploring, and perhaps other opportunities for doing this, other frameworks might exist. We would like to consider education for patients as a part of survey administration so that they might better understand the importance, value, and use of this. Perhaps we want to involve community health workers. Some have made this suggestion, or others on the clinical team in the educational process. Changes in sampling methodology seem appropriate so that people who have been exposed to specific care activities are the ones asked about those specific care activities. And that if you want to go take a deep dive on specific groups of patients, that is something that's feasible to do to understand those patients better and their experience. We want to increase support for quality improvement activities. Karen talked a little bit about some of the work we're already doing, but we think there's additional opportunity to improve it and maybe do it in different ways. And then the databases and data collection that we have for reporting and research, and also benchmarking. We would like to look further at those. Some additional emerging possibilities that we think are worthy of exploration are here. And we know that vendors are using some or all of these, but we wonder if there might be a role for them in our work. So new data sources like social media or sentiment analysis. And then, the technology, some of which you've discussed earlier today, but human-centered design to enhance response rates, natural language processing or AI to analyze narrative responses, online review platforms for administration, what could we gain from mobile apps or interactive voice response systems, chatbots, or gamification. We don't have the answers, but we have the questions. So having identified areas to fix and ideas to explore to address the concerns, we've then identified a feasible timeline for our work. And we've put it in 3 buckets: short, medium, and longer term. We've already begun making some of the short-term changes, especially since 2 of our newest staff joined the CAPS team in September and increased our ranks. We've already begun strengthening our channels of communication with CMS and have engaged with OECD and other researchers on latest research on patient experience and some patient safety that intersects with patient experience. Improving our communication is another immediate focus. We talk over and over again about the patient experience satisfaction and PROM confusion, and we need to really work on solving that. We want to strive for more effective dissemination of CAPS research and findings to address the limited knowledge on specific topics where we do have some answers. And these include about administration modes, ways to improve response rates, and also use of narrative items and ways CAPS measures things that are critical to patient safety. And finally, we are continuing to work on clarity of our roles and in CAPS development and administration so that we can work together to address issues in which we all have a piece of the puzzle. So that's what's going on now. And then we have the medium term. We propose tackling bigger issues in each of these 4 categories. And I've already mentioned these areas of work, but now you see here how we propose to work on them. So in patient engagement, identify and adopt a framework for that. I talked about the PCORI one that's out there, but there are others. Work on confirming that our surveys are focusing on items important to patients, address the relational aspects of care. And then in development and administration, the topped out items, survey length and complexity, sampling requirements, modes, response rates, and representativeness. That's a lot, and that will bleed into the longer term as well. Education is something we also feel is very important and want to increase that on value and use of CAPS, education for patients, the clinical team, and on the value that we know about CAPS and changes in patient experience and other outcomes of importance. And then finally, our quality improvement resources, which we're starting, but would like to deepen our work in that in the medium term. So we've identified specific issues to address in the short and medium term, but there will be more that has to be done to fulfill the vision. And in the longer term, we propose to deepen our work on the issues that will definitely take more time to address. And in addition, we are proposing a systematic process to gather substantial external input and a synthesis of 30 years of research on CAPS to use to generate a roadmap for the work for the next 30 years. So this would include an environmental scan. What else is being used now to measure patient experience, and what is the rigor and value of those existing instruments? We've talked about an evidence-based practice center report to synthesize evidence on multiple topics. As Karen mentioned, there have been over 500 articles published on hospital CAPS alone. And the last review of the association between CAPS and clinical outcomes is now 10 years old. And then last but definitely not least, our roundtables or TEPs, technical expert panels of a lot of different groups. So a variety of patient groups, I think, would be critically important. But we also are thinking of payers, clinicians and health systems, data scientists and emerging technologists to help give us information on all that new stuff that's happening out there that we need to understand and is rapidly changing, vendors, and quality measurement professional groups. So we wouldn't be ARC if we didn't also talk about how will we know if we have succeeded. So we have this here. We've got to figure out what the measures of success will be. We've put here, the first 2 are pretty darn aspirational, that we improve patient experience. And yet that will be very difficult for us to measure at a national level, but it certainly, that along with our increased brand recognition gives you an idea of our lofty goals. But the others are a little more granular. Improved response rates, decreased cost and lag, increased use of guides and resources, and increased submissions of data and research activity are some ideas of how we will be measuring our success as we go forward. So as you've heard today, CAPS is just about to celebrate its 30th anniversary. It was groundbreaking and it remains the gold standard. Yet we need to build it, strengthen it to go the next 30 years. We've organized our work into short and medium and longer term priorities. And we're very interested to hear y'all's thoughts on, are these the right priorities and timing? And if not, what would you change? And then if we could wave a magic wand for additional resources quickly, what longer term priorities would you work on now? So thank you for your attention, and the CAPS team and I look forward to your thoughts and ideas.
Great, thanks, Laura and Karen. Let's, I see your hand, Mary Beth, but before we get there, I want to have a couple groups report out on their findings of the discussion from this morning. And then, so I'll call out a couple of groups, and then what we'll do is any other groups that feel like they want to add points that weren't already raised by those first two groups, we'll kind of take it that way. And then we'll kind of just open it up more generally. So I'm going to start because the folks who are remote often kind of get forgotten about. So I'm going to start with those guys. And I think Kanan was the reporter for that group.
Wonderful. Thank you, Edmundo. I presume you can hear me okay?
Yes.
Great. Thank you. The group that we had included Mason, myself, Liz, and Mario. So I'll start off by reporting, and then I'll invite others to weigh in for things that I might have either missed or edit anything that I might have said that I might end up saying here. So overall, I think our group strongly felt that CAPS has been doing a wonderful job in terms of, for the last 30 years as related to the surveys and looking at patient experience measures overall in general. And also congratulated the CAPS group in terms of the methodology and the science behind the work that's been done in the last 30 years. I think some of the issues that we brought up as a team, as a group, were already highlighted by both Laura and Karen, but I'll just try to see if I can emphasize some of those things again here. And this basically ties down to our ongoing evolving healthcare demands and the technological advancements that need to be kept in mind as we continue to make some changes to CAPS moving forward, which nicely aligns with what the short, medium, and long-term goals that Laura put forth out there. And I think we overall agree with that. And in addition to that, we thought we'll add a few more for consideration here. And that's one of the things that we thought of is to look at prioritizing integration of CAPS with some of the digital platforms and adapting the surveys to meet the needs of the modern healthcare landscapes. And this is where leveraging technology comes into play. I know Laura touched upon the AI LLM, but in addition to that, I think it's the integration part with the EHR and digital platforms that might be of some help here, including aggregation to larger data sets to better serve some of the healthcare systems and providers as well. The other aspect that our group brought up was trying to see if there's a way to personalize some of these data points that are being shared back so that if one is looking at quality improvement, it just becomes a little easier to address it based on the groups that it's are targeting at that point. And this brings up another aspect that our group talked about, which is making sure that the survey is looking at, let me see here, just to making sure that it's who in terms of clarifying who is the target audience and who and what is the purpose of the survey. I think it was highlighted by Laura and Karen, but I think the target audience, though it's patient-centric, the question is also the fact that the providers, healthcare institutions are also engaging. So having a voice being heard from them so that when the data is shared back, if you're looking at quality improvement, I think it makes it important that the voices of all stakeholders are considered, both in terms of putting the survey together as well as sharing the data when it comes forth. From a leveraging technology perspective, I think it's also important to see if there's a way to get some real-time data And I think Laura highlighted this because if you have data that's coming up after a year or two, then the ability to do some continuous quality improvement lags behind. So real-time data availability to providers based on input from patients on the surveys might make a big difference out there too. And I think I'll close it by saying that looking at some of the strategy collaborations with some of the health technology platforms and patient advocacy groups to continue to enhance reach and impact is going to be important and helpful as well. So I'll, if time permits, Edmondo, I was going to see if Liz or Mario have anything to add to what I just reported here.
Sure. Yeah, Liz or if anyone else is on from that group one.
I can just make one comment. Thank you. That was a great summary. And congratulations on the great history of CAPS. I just want to add that we did discuss the importance of some degree of urgency here to make changes. And you have short, medium, and long. And we talked about trying to accelerate these changes, particularly focused on taking advantage of digital technology, because there are a lot of other ways in which provider groups are using other tools for patient experience. And notwithstanding the fact that the CAPS is still associated with accreditation and P4P, but provider groups are spending money on other kinds of tools to actually drive improvement. And I'd hate to see that movement somehow get in the way of you doing your transformation.
Great, great work for group one. Thank you. I'm going to call out group two, and Cindy's going to report out for that group.
Hi, thank you so much. And again, congratulations for 30 years of this work. So we first wanted to provide some overarching input as opposed to just going to the short, medium, and long. I think our first observation is that it's not aggressive enough. And I think that aligns with what the previous presenter was saying about acceleration, that there needs to be a lot more concrete action. The other thing that we identified is that, there were different categories for short, medium, and long. And that one of the categories that was missing was data analytics / methodology and business intelligence. We think that's a really important aspect and use case for CAPS data that needs to be kind of called out. Some of the bigger picture ideas that we had was, is there a way to think about a patient experience never event, the way that we think about, never event from a clinical perspective? The other question that was raised is, how do we prioritize the list of all the different things that we want to improve in the context of a rapidly shifting healthcare funding landscape, especially in terms of like federal funding? Other questions that we had that are overarching or, cross, the short, medium, and long is, what are the plans and how are we ensuring that there's data stratification across all measures and that they align with the new OPM categories for race and ethnicity under Statistical Policy Directive 15. Another priority was, how is there a way, and this is as much a question I think as it is a priority, of how can we align and connect the dots between patient experience outcomes tied to actual clinical outcomes? Is there a way to identify certain patient experiences that can be kind of predict challenges or ways to avoid negative outcomes? And then the other thing that came up in general is we really need to look at the burden to providers and to patients and think about, really strategically about measure substitution. How do we take out the top ones, add new areas such as, telehealth, bias and respect, and more patient-reported experience, patient-centered outcomes. So in the short term, the big question is, where are the KPIs? some of the recommendations we had was to make sure that under collaboration, that there is a lot of collaboration with the other measurement evaluation groups like Joint Commission, like PCORI, like NCQA. And one, new recommendation or proposal on how to operationalize a lot of this is to start planning for something like a national impact assessment for CAPS, like the one that exists in CMS for CMS, that has really strong patient community focus and that looks at all the environments of care, including, telehealth, for example. And of course, to really focus on how to plan out and make concrete a data analytics and business intelligence pathway that includes integration of the new OPM categories, that assesses how much stratification by these categories is actually happening, and how can we actually take the data that we get to curate actionable data for different settings of care. I think for the rest of the categories are pretty much align with what was very, has been already mentioned, including, planning for the evolution of, but a new one would be planning for the evolution of digital tech. And, what are in terms of the magic wand, I think one of the things that was of a lot of concern is how do we capture the behaviors that include sites of care that are not currently included, such as online care, telehealth, the going into, minute clinics, et cetera, those kinds of areas of care that have not been traditionally included in the CAPS framework. And if there's anybody, if I missed anything, please from our little group, if there's anything they want to add.
Peter, jump in. You were in that
Yeah,
group.
just very briefly, that was great on our thought process. Is the only other that we briefly touched on. We're seeing it happen in higher ed already, and that's the institutions behaving towards the survey results. So how do we better identify and perhaps mitigate healthcare delivery systems, whatever their environment, from not just playing to the HCAHPS results?
Playing to the test. Any other comments from our group on that? Yeah, good work. Thanks for taking those notes, Carrie. All right, so with any of the other groups, groups 3, 4, 5, anyone of the reporters from any of those groups want to jump in and add anything that's additive to the comments that have already been made by the first couple of groups? Go ahead, Kamal.
Thank you, groups. Just a few other things to add and underscore, because we also acknowledge that the advancements in technology really help sort of unlock what we can magic wand and dream about. A few sort of granular things that were not described previously. One, slide 4 of the presentation has roles and activities, and slide 6 has uses of the survey. Research is listed as at the top. When describing the program, we fully acknowledge this is not a prioritized list, but sort of human behavior, it's listed research on slide 4, but yet the top use was listed as quality. So just something to sort of think about as we think about the messaging. The other thing is on the listening tour, just wanted to double click, it was mentioned previously, sort of the inclusion of listening to technology partners, including naturally EHRs. I think the other, to double click on Peter's point, and surveys promoting what hospitals and other health entities work on, clearly articulating, or I should say re-articulating the link between care experience and safety, I think is this a really important one. And there probably are new research questions sort of in this new era that might be, sort of help further with that re-articulation. We also recognize it was acknowledged that education when completing the survey is important. We were also thinking about, the reports that are already available on websites for consumers to look at. Yeah. And is there a way of making those more accessible, more graphics, things of that nature, to really help folks understand really what they're looking at?
Great. Other additions? Personal.
So I'll add incremental comments from my group. First of all, thank you for 3 decades of work in this area. And many of the things that you highlighted from your slides came up in our group as well. A couple of things to just underscore in terms of challenges with the current measure are a big issue for our small group was just the very, very low response rates. And that drives some of the recommendations, which I'll give in a moment. We also noted that the questionnaires are quite episode based and don't necessarily take into account the pre-visit and post-visit experience and everything that's happening in between. The exchange of information during that time period is a big part of the patient's overall experience and isn't reflected as well currently. In addition to new dimensions that you brought up around discrimination, one that's not well covered in the instruments now is cost, particularly with financial toxicity of healthcare bills. That seems to be a very important part of patients' overall experience with their healthcare. And the current questions don't necessarily elicit patients' perceptions of the quality of care or safety of care that they receive. So we measure those things on our own metrics, but patients have a unique window into that and might be able to comment on the timeliness issue, for example, around care. If we're not capturing that as well in our current measures, this could be a good opportunity to supplement from the patient's perspective. I'll mention just some incremental things around short, medium, and long term briefly. In the short term, we thought that the measures should be made available in more languages. And in going through that translation process, it would be important to make sure the terminology is culturally appropriate. One of our group members pointed out that the questions were probably developed with the frame of mind and communication preferences of a majority group. And we need to be more attentive to language and terminology usage across cultures. One of the research papers that had stuck out to me from reading this literature is how Asians tend to give a lower rating than other racial groups. Is it possible to create some analytic packages which would help sort of normalize aggregation of responses, risk adjust, if you will, when we know that there are certain differences in response profiles by groups, yet we're aggregating data as if it's all part of one group. That could help hospitals and clinics that serve very different demographic distributions of patients. We should also seek out collaboration with other industries that have a lot of experience in surveying customer care. I believe you alluded to that in some of your comments. And the opportunity to use mobile devices to increase response rates was something we also thought could be done in the short term. And our understanding is that only the responses completed on the paper survey roll up into the reported metrics. And so we're not even fully utilizing data that we currently collect, either through mobile or other electronic technologies. That's something that really should be addressed with some urgency. In the medium term, a few things that additionally came up in our group were learning from patients, especially from diverse groups, what matters most to them. There might be an opportunity to focus in on different aspects of the survey as we sort of refresh our understanding in the modern era of what domains matter most. A comment about, well, using the written comments to gain more insight from patients provides an opportunity to use AI in a way that we just couldn't before. And that seems like a tremendous opportunity right now. And just looking incrementally. Longer term, this would take a large amount of work, but it was noted in our group that there are so many different versions of the survey, and they're all quite long. Is there an opportunity to completely revamp the way it's being done? In other areas, for example, patient-reported outcomes measures, we use adaptive surveys. Couldn't we introduce something like that into patient experience assessment so that we can more quickly capture the essence of what patients are telling us, or even allow them to select certain domains that matter most to them and respond to only a portion of the survey? there should be a way analytically to still get high value analysis from that while lessening the survey response burden. And also, the last thing I'll say is right now, analytically, it seems that the questions are all taken with equal weight. And as we move to more personalized care and recognizing that for some patients in certain settings, convenience might be more important, value might be more important, communication and relationship might be more important. Should we really be weighting all the questions and domains equally? Or is there a future state where patients could focus in on domains that are most important to them, or even within a survey, items are weighted differently as we aggregate the responses? That's very much a long-term thing.
Thanks for that. Great points. And it reminded me of one of the discussions that we had around. It was a little provocative, so I'll caveat it before I say that with that. But the idea that you know, can we copy the way that Amazon surveys you, right? So I say that a little flippantly because Amazon doesn't survey you, right? But they know a lot about you, right? And so what is that? What are we missing there, right? And is there something we can learn from that approach, right? By observing and or framing or setting up ability to observe actual actions and activities from those patients, that we actually can start to understand what their experience is like based on actually following them. And is there a methodological approach to that actually carries water in some way, right? So that was, I mean, it's pushing it a little bit from a provocative standpoint, but you know, when you start to weigh in all the technology that's coming down and the different ways that people interact with the world, you know, paper surveys are just like that's just not going to be the way you're going to be able to get anything from anyone anymore. So someone asked me to send them a voided check at some point, and I'm like, I don't have checkbooks, right? Like I can't send you a voided check. It's just these certain things are just going away, right? And so we don't want to be 10 years behind, still trying to get a voided check from everyone. And when there's other ways to do these things. Any other additional, either from a group report, there's one group I don't think I heard from, or just general comments or questions for this. Ashad, I think I see your hand up. Mm-hmm.
First, thank you for 30 years of CAPS and all of the research behind it. We are obviously a major user of CAPS, and you're not going to be surprised about what I say. I just really want to emphasize that this has to be accelerated, because CAPS, frankly, has become fossilized, and it's not meeting the needs of what our agency needs and what healthcare needs. The response rates are too low, the surveys are too long, to the point where CMS has on some occasions gone out and developed their own patient experience tools. We did it for inpatient psych. We're looking at it for maternal care. And that's not the direction we want to go. We want to be good federal partners and align with you and be part of this work. But you also know we're sitting on our IAA until we can see that CAPS is going, interagency agreement, until we can see that CAPS is actually going to successfully be able to move and be more responsive. You know, you've heard all over, there are multiple opportunities, even in the short run, even to make these available by mobile devices in the short run. That's not a necessarily long-term ask. That's technology that exists now. Making these available in different languages, that there's technology that exists right now. Seeing if there's some way that we can even make them shorter, like right now, if that's possible. But we love the direction that you have set out here. But also know that even in a very specific example of a CAPS that we are looking with AHRQ to change, that the changes weren't going to come until 28, 29. By the time it gets into a CMS program, you're talking about 2030. It's not enough. We're going to be behind by the time we have the new one. And so please accelerate this. We want to be good partners. We want to be in this with you. But this has to be more accelerated than I think what the urgency is. So thanks.
Good call out. Consistent theme, I think, across groups. Jaji, you're up.
I just want to follow up on Michelle's comment here, acceleration. I think today's technology is already here. It is being used by a lot of industries. For instance, conversation-based data collection. You can get any language to any reading level, culturally sensitive. You can get data collected in real time by speech on a cell phone. So if you use this technology, you can redesign everything. You can collect data in real time and get data analyzed, of course, by data science, AI, and even for the data you already have. As mentioned earlier, you can go over there, do some data mining. A lot of information over there. I think you can just discover, present it in a way that is targeted to a specific population. But again, I just want to say that technology is already here today and is being used. And so that's my suggestion.
Thank you. Spot on. Michael.
Thank you. So when I looked at the uses of CAPS, I kept on staring at that. And public reporting, QI, certification, value-based purchasing, health services research. And really the question is, can one survey make all those folks happy? And you know, you're asking a lot of terrific questions of a lot of great people, but your analogy, Laura, to start with about the construction is not a bad one. And sometimes a 30-year-old house needs updating, and sometimes, as they did with this building, they gutted the entire interior. Because I remember what the old building looked like. And the fact is that the original idea for CAPS would have worked great. Everything happens through your health plan, the whole managed competition. And if we just survey health plan members, they can tell us about everything, inpatient, outpatient, the health plans, right? And now we split it up into the wonderfully complex American healthcare system. And we have inpatient, outpatient, I mean, all the different kinds of things that you're trying to do. And you end up with something that's run by, I love them, but health services researchers. That's who's running this thing. And by God, I have something with is methodologically rigorous. It may not be useful, but it is methodologically rigorous. And I can publish on it. And after I publish on it, I can cite everybody else who's published on it for the rest of my life. And that's great, but that's what we have. And but meanwhile, you have Google and you have Yelp and you have social media and all the rest of this. And so the question is, how do we use, maybe we rename CAPS, to drive improvement? How do we use surveys to drive improvement? And maybe you gut the house and say, well, maybe for public reporting, we have the feds make a deal with Google or Yelp to, you know, have a different kind of survey. And should it be for QI and value-based purchasing really? And all right, there's so many different things. How would you look at the forest as opposed to each individual tree? And that's sort of what I recommend, the actionable transparency. I'll just give you one small example. The compare data, okay, because it's clinical and claims, it's updated with a lag, which is understandable, that it's posted and it's, you know, put up there and I can find out what happened in 2019. But with survey data, lo and behold, it could be on a rolling 1 month basis because there's no lag, and you could post it on someplace where SEO found it, or you could require the hospital to post it. So it would be actionable and salient. Right now, it's not salient, except to the people who can publish in HSR and every other journal for the next 20 years. So the question is, how do we make this salient to have quality improvement? And you've had such an incredible group of people giving you feedback. And I think that's wonderful, but you sort of need to peel it back and go, okay, how do we accomplish our main goal, even if we have to peel off some things in the meantime? So that's my sort of overarching construction recommendation.
Thanks, Michael. I love that, provocative and I want to call out one challenge that I don't envy that you guys have to deal with. When my early research career, because I'm one of those health services researchers, Michael, by the way. In my early research career, I was looking at, I basically I called the concept "no hospital left behind." It was when we started the public reporting, right? And they said, "Oh no, there's no consequences. We just want to publicly report," right? We all knew what was coming, right? We all knew what was coming. But we also knew that it took a lot of resources to actually be able to change in the ways that you could get to the top versus not get to the top. And so you knew that the hospitals that had the more resources were going to be at the top, and the hospitals that had less resources were going to be at the bottom. The hospitals that had less resources were taking care of underserved populations, and you just knew where it was going, right? It was very clear. So I say all that to say that part of the challenge around CAHPS, in this case, it was hospitals, so it was HCAHPS specifically, is that it's high stakes now, right? It's high stakes. And so changes are going to have implications that are high stakes for folks. And so that's part of, I suspect, what you have to deal with as we think about all these really innovative and cool ways, right? Including what you're saying, Judgy, right? Like all that sounds great until some, hospital or health system says, wait, if you do that, we're going to go from up here to down here. And that has this bottom line implication. And no, you cannot do that. Right. And so that's part of, I think, what folks have to deal with.
And that's about why you don't use it necessarily for all the different purposes. By the way, I once talked to someone from a hospital that had incredibly high CAHPS scores. They were a 15-bed hospital. The nurses knew everybody who came in from the community, right? That was one way to get a really high CAHPS score.
Well, and one just said, and put it on steroids for nursing homes.
Right. Right. Very much.
Any other comments before we close out this section? Peter?
Sorry, just a quick afterthought. I'm surprised that the whole encroachment of private equity into our healthcare delivery system hasn't come up at all yet today. And yet, as we know, there is ongoing investment. There's alternative care strategies coming into place across a whole variety of environments. And yet some of the early research data is showing a deteriorating impact on quality and safety and outcomes and all those sorts of things. And so as we think through CAHPS, HCAHPS, et cetera, how do we anticipate where this private equity investment is going to take us, or bring the camel into the tent and get some investment with private equity to help redesign?
I will say, just apropos of that, there was an article that was either in JAMA or JAMA IM in the last week or so that looked at using patient experience measurement, that looked at the spectrum of patient experience from for-profit private equity, for-profit and not-for-profit. And there was a clear spectrum. And the for-profit was not as good as the not-for-profit, and the for-profit private equity was the worst. So always better to be in a place where people know your name and care about you and from your community. I will find it. Yeah, sure.
Excellent. Well, thanks again to Karen and Laura for this framing this conversation up for us, having a chance to dig into it this morning and then share some of our feedback. Hopefully that's been helpful for you all as you engage in this challenging but really important work. So thank you. Let's move to the next agenda item, which is public comment. So we do have a couple of public commenters. So we're going to start with Stephanie Mercado, who's CEO of the National Association for Healthcare Quality. Stephanie.
Hello, good afternoon. Thank you so much for having me. I have appreciated listening in on this session and have a few remarks to make. First of all, I really appreciate the discussion on measures and alignment and all of the hard work that has been done and the additional work that is ahead of us. One of the things that I am drawing in on is a comment from one of the last speakers who talked about driving improvement. And I just want to acknowledge the effort that has been taken on and will be taken on to drive improvement through the workforce. So when we think about workforce development and workforce readiness to advance all of the quality and safety goals that we're talking about here today, it occurs to me that we have 5 generations of individual contributors working in healthcare, from the front lines to the board and C-suite, who have been trained differently or not at all from a competencies and skills perspective on quality and safety. And so while we pursue with great interest, the goal of quality, safety, equity, and value, we have not yet placed sufficient emphasis on the education and training of that workforce in a united fashion. So I just want to point out a couple of things that are going on to advance that, and call on all of us to continue to think about workforce readiness and competencies to achieve our goals. So first of all, I want to take the opportunity to thank AHRQ and the work that they've done on the National Action Alliance. I think that it has been heroes work. I've been part of that as well and appreciate it very much. And I specifically want to acknowledge the work and the language in that document around commitment, around performing organizational safety assessments and identifying plans and gaps, and also the competency nod that was given in that report. I also think it's incredibly important that CMS, through the structural safety measure, is now requiring implementation of a patient safety curriculum, patient safety competencies for all clinical and non-clinical hospital staff, and regular assessment of these competencies. This is huge. I believe it is game-changing in healthcare. And I think that the American public would be surprised to learn that we don't already do this. So I'm really glad that we're doing it. It was the right thing to do. And we are in 100% support of that. I also want to point out that pursuant to that as well, just this week, yesterday, in fact, NACU released an announcement about an alliance we have formed with the Joint Commission. Our alliance is focused on taking all of this competency work that we have been doing for years to the next level. And what it signifies is an endorsement from the Joint Commission of NACU's Healthcare Quality Competency Framework, and the endorsement of our certification, the CPHQ. I think, and excitingly, we're going to be co-funding some scholarships for CPHQs in underserved areas. But I think that the real important message here is that there's a lot of competencies out in the environment, and all of the people working in healthcare have been trained on quality and safety in one way or another, and that's great. We need the clinical competencies in medicine and nursing and all of the other disciplines, even the non-clinical ones. But the time has really come for a standard set of foundational and universal competencies that the entire industry can rally around. And I was really excited to see that the Joint Commission is adopting NACU's competency framework, and we look forward to the entire industry adopting this, not as a replacement to any other competencies are out there, but as a foundational and universal component. So we are here, we are ready, and we are able to support the workforce and leveraging them to their absolute fullest potential.
Thank you, Stephanie. Next up, another Stephanie, Stephanie Alosi. Is she in person or?
No.
Oh, okay. She's on Zoom. Okay. Oh, there
Hi.
she is. Hi.
I'm going to go really quick because my understanding is I have limited time to speak. Can you hear me? Great.
Yes.
I'm actually here to speak on the importance of tracking health.
Okay. We'll come back to Stephanie. Let's go to Helen Bushnell. Whoa. I see her.
Okay. So I am, I'm a patient. I have end-stage kidney disease. And I live in Colorado, and I have experience with the Kaiser system and also UC Health. Both of those systems need to have better means to track patient outcomes, especially illnesses acquired during treatment. I frequently get small illnesses like novavirus. There's a particular facility that Kaiser has where I often get sick when I go there, and I also notice that they have a lot of jobs that are not getting filled there. which I think puts stress on people who do work there and puts stress on the people who go to that facility. Right now, it feels like they're trying to get, both those systems are trying to get reviews for their website rather than get actual feedback from patients. And I do have a particular concern that things like COVID, serious illnesses, I think it needs to be tracked better on both ends. COVID needs to be tracked, but also these smaller illnesses that people pick up sometimes when the sanitation is not so good. And usually you can tell when this, like, I can tell the difference. I can look between different Kaiser facilities when I walk in. I'm usually not surprised when I have some kind of like diarrhea the next day. It is always like there's one place I've never gotten sick. I've never gotten sick when I've gone there. Even if I'm already and I actually go there because I take immune suppressants. So I think that needs to be tracked. The overall sanitation needs to be tracked better, and the effects of maybe issues that are happening at particular facilities. Okay, and thank you for listening to me.
Absolutely. Thank you. We're going to go back to Stephanie Lowe, see if she's back up. There she is. All right, let's see. Let's try this. Let's try take two, Stephanie.
Hi, I'm also here to speak on the importance of tracking healthcare acquired infections, specifically COVID infections. I feel personally invested in this conversation as someone who was diagnosed with a rare acquired genetic mutation in 2020, and that's opened me up to the possibility of several cancers, and most notably a class of rare bone marrow disorders called MPNs. My condition is closely monitored by a hematologist who I see at an oncology center several times a year. Navigating the US healthcare system during COVID has felt really scary for me as someone who lives with a high platelet count and knows that COVID is responsible for increased stroke risk and cardiovascular events. But despite this, I'm not eligible to receive vaccine boosters reserved for the medically vulnerable because my condition was not included when drafting an eligibility list. And this has left myself, as well as other Americans, some of whom are also medically vulnerable, completely unprotected from COVID for about 6 months out of the year, save for masks, which is frustrating. And what is perhaps the most frustrating part of navigating COVID has been witnessing some healthcare facilities and hospitals that I had previously entrusted with my health refuse to adhere to basic infection control measures, including masking around their patients. And a few examples come to mind, like last year during my colonoscopy, when my medical team refused to put masks on of their own after removing my own mask in order to intubate me while in a sterile procedure room. Or last week, when I ran out of an infusion center without getting the ferritin infusion that I need, in part because not a single member of the staff was wearing a mask at an infusion center inside a hospital where I sit alongside oncology patients who are receiving chemotherapy. I cannot tell you how many dentist appointments I've gone to where I've been forced to take off a mask without being able to rely on my dentist not to have his removed when not just hovering immediately over my face. Or how many doctors have stopped me while walking into a facility upon seeing my mask because it's assumed that I'm sick, not that I'm actually protecting myself, and they're concerned about getting sick from me. COVID has made masking political. It's totally changed the way healthcare workers use them, and it's led to a lack of infection control and disregard for the most vulnerable people within the healthcare system. Those who are charged with caring for the sick have become an actual danger and a liability to them. And what I'm about to say, I feel is important. I feel that we're reaching a point as a society where we could look back on this point in time and think of it as eugenics. I feel that the healthcare community doesn't care about my life. It doesn't see it as valuable. And it feels demoralizing to beg for people who are charged with helping me when I'm sick to please not expose me to a deadly illness. And it feels worse when they say no. Without clear data that shows that hospitals and healthcare facilities are actually harming patients, I don't believe that there's any hope that we're going to return to infection control like we saw before 2020. And I urge you to take all measures possible to hold healthcare facilities to account, including tracking healthcare-related COVID infections in an attempt to leverage healthcare facilities into implementing masking as a standard practice. Thank you.
Thank you. I think that concludes our public comment. Yep. Okay. So we are in the home stretch, folks. We're in the home stretch. So of course, I always have the benefit of the chair's wrap up, which is kind of like, do what you want. So I like that. And as this is my last in-person chair meeting. I'm going to take a little bit of advantage of that, but I'm also going to spend a little bit of time with the other folks who are finishing up the end of their term. So I'll start by calling those folks out, and if you have any kind of parting words of wisdom for the NAC members who will remain and stand on your giant shoulders that you've left them, please do share. And I'll start online. So Kanan, if you're there, any words of wisdom or parting shots you want to share?
No, I appreciate the opportunity, Edmundo. I think for me personally, it's been a wonderful learning journey for the last few years, not just learning from others, but learning about myself in the process, and hopefully trying to be a better provider at a better healthcare institution as well too. I'm not sure I'm going to be able to impart any wisdom that others are already having at this stage. The only thing I would maybe advise is continuing to probe, ask questions, have ongoing transparency in terms of discussions like the ones that we've had today, and hopefully try to push for some actionable items at the end of the day, because I think we discuss a significant amount, but I just want to make sure that these are converted into some actionable tactics or strategy in the near future so that we can see it come to fruition. So really appreciate the opportunity, and it's been a wonderful time serving on under your leadership as well too, Edmundo. Thank you so much.
Thank you. Next up is Gina.
So I want to thank Dr. Valdez and our wonderful chair, and all of you. I've had such a wonderful and valuable experience. It's not often that you get to collaborate with other healthcare colleagues of different experience and perspectives. So it's just enriched my own perspective. And I've been able to take that back to my colleagues and promote the work that ARC is doing. A lot of people do not realize all of the valuable tools, even that you put out open public comments, so I encourage my colleagues, make sure you're responding to those open comments, make sure, you're looking, there's all these valuable resources that we need to share. Yeah. So that's what I plan to do moving forward, and to stay connected to ARC's wonderful work. But thank you.
Awesome.
Appreciate the
Thank
opportunity.
you. Jaji.
So when our cohort started, ChatGPT was not even released.
That's right. That's right.
Today, it's changing everything fundamentally. So I do encourage current and future members to drink some old-fashioned cocktails and start some fresh new ideas, including a subcommittee on AI efficiency.
Thank you.
Thank you so much.
Thanks, Joshi. That's awesome. That's awesome. Did I lose Krista? I think we lost Krista.
Yeah.
Oh, she stepped out. Okay. Come on, you're up then.
Thank you, Dr. Valdez and the ARC team, for a remarkable 3 years. Jaji, as you just said, ChatGPT didn't exist, and now here we are, right? There are so many things that we have learned. And as we move forward, the work continues. I sort of think about the combination of innovation and basic practices like humanity and care, right, will move us forward. And so the true north stands, right? Regardless of all of the things that are being thrown at us as it relates to healthcare delivery, the true north stands, that we are better and stronger together, and we can and must do better.
Yeah. Outstanding. Not seeing Krista, I'll share a word here. So if I remember correctly, and Jamie will correct me if I don't remember correctly, that's one benefit of having her sit next to me. is I started around spring of 2019 on the NAC. So just take a moment to think about what's happened since spring of 2019. A few things have changed over that time period. The world has changed in a lot of ways since then. I remember when I started as chair, I'm pretty sure when I started, we were in the height of COVID. So like I was chairing remotely. It's a whole talent and skill, I think, to try to get engagement when everyone's remote, right? But it's an advisory council. You really need people to feed it. That was a whole thing. But the NAC members then and now have always stepped up to the challenge of their charge, which is to provide the director and the rest of his team with advice, recommendations, even challenge where necessary. And so I always appreciate and continue to appreciate the tremendous talent, diverse thought, and engagement of this group. It's been really powerful in the time that I've been here. I have to, of course, thank the team. Yes, Jamie, amazing, right? So I think I've really enjoyed being the chair. This is my favorite. I chair a few things. This is my favorite, I'll just say. And it's but the team makes it easy actually to do this work, and allows me to not worry as much about the logistics and really dig into the challenges that are on the table, the charges that the director and the team are putting in front of us that we really have to dig into. That is where we focus our energy and attention. That's because the team has allowed us to do that. So thank you. Over the time period, right? So as we're going, for me, since I don't officially end until March, so that'll be my third administration, right? As ARC has navigated a lot of challenges over that time, and we've had some really interesting conversations over that time period. And ARC has navigated a lot of challenges over 35 years as well. But the work remains. The work to improve the health of those that we serve remains. The language that you use, the tools that you use, those may change, but the work remains. We have a lot of work to do. We've made a lot of progress, but to Michael and others' points, we have a long way to go. And the importance of the work that this agency does and the advice that this council provides to this agency is critical. And I remain proud of my association with ARC. So thank you all for leaning in over my 6 years here, and certainly my charge is to continue that moving forward for those who are staying in the staff, and for those who are rotating off. As they often say, you are always associated with ARC even as you rotate off, and they will be tracking you down. They will find you. So, but thank you. This has been amazing, and I really appreciate you all. With that, I do want to thank Dr. Valdez and Sean, Taz, Craig, Jade, Laura, Karen. I think I got everyone in terms of for their presentations. Again, all the NAC members in person and online who joined. The next NAC meeting will be March 20th. It's planned for in-person for now. More details will come out. But with that, I will certainly entertain a motion to adjourn. So moved. Anyone second? And second, all those in favor? Aye. Thank you. We are adjourned.